Hello everyone, and welcome to the 6th International Health Sciences Conference, Odontology and Maxillofacial Surgery session. My name is Ieva Pratkuta, and I will be leading this session today. First of all, on the behalf of the Student Scientific Society of Lithuanian University of Health Sciences, I would like to thank to our patrons, Fresenius Kabi, Roche, Medita, Origmed, and others for helping us to organize this conference. We believe that it provides an opportunity to all participants to share their interests and achievements in various biomedical fields. We hope that International Health Science Conference will help build friendly and professional relationships and share experience in fundamental medicine, biomedicine, odontology, pharmacy, and public health with your scientists all over the world. Additionally, I would like to express gratitude for all the reviewers and today's jury. So I would like to present the jury now. First, I would like to introduce Association Professor Marijus Leketas. Association Professor Greta Lodienė, Professor Gediminas Žekonis, Professor Dainius Razukevičius, and Jan Pavel Rakitsky. We kindly ask jury members to remain at the session until the points are counted and the winner is announced. Before starting the session, I would like to remind some rules. Today, we will hear 9 presentations. All the presentations will be evaluated by jury. Based on the average scores given by jury, we will choose the one winner from this section. The winner will get great sponsored awards, gifts from Bioderma Sapiens, Chrysostomus Bookstore, Origmed, Gintarinė vaistinė, Fielman, and Medita. Winners will receive their gifts after the session. Moreover, presentations should last no longer than 7 minutes, and after that, 3 minutes will be dedicated for the questions from the jury members and listeners. Please know that if your presentation will take more than 7 minutes, you will be asked to go to the final slide and finish your presentation. I ask the jury to fit in the given time frame as well. Moreover, each presenter will receive a certificate that will be sent to their emails after the conference. Does anyone have any questions before the start? Okay, so best of luck to all the presenters now. And now I would like to invite the first presenter. Ieva Gudalevičiūtė, with the topic, the efficacy of biomodulation therapy on patients with temporomandibular joint disorders, systematic literature review.
So hello, my name is Ieva Gudalevičiūtė. I am 4th year student of odontology, and today I am going to present systematic literature review, the efficiency of photobiomodulation therapy on patients with temporomandibular joint disorder, or TMD. I would like to start by notifying why this topic is relevant these days. So temporomandibular joint disorders prevalence in the society is larger than 5%, and more than 12% of patients have experienced clinical symptoms that can be such as jaw discomfort, clicking of the jaw, pain in the temporomandibular joint area, headache, reduced mouth opening, and others. Such disorders are multi-etiological. It means that they are caused by biological, behavioral, social, and cognitive factors. And speaking about treatment, temporomandibular joint disorders are usually treated non-invasively, and in the recent decade, more and more discussions arise about photobiomodulation therapy potentially being an effective non-invasive treatment for TMD patients. Therefore, the aim of this review was to assess the efficiency of photobiomodulation's application while treating patients with temporomandibular joint disorder. Now I will present methods. So PICO question was, is the application of photobiomodulation treatment on TMD patients more effective than a control group or other methods? All data was retrieved according to PRISMA criteria. For information research, we used PubMed, Cochrane Library, and Science Direct electronic databases. And keywords that we used: photobiomodulation therapy, low-level laser therapy, TMD, TMG disorder, and treatment. Then 32 sources were sampled from 100, and after that, by applying sampling criteria, that was photobiomodulation clinical trials on treating TMDs, studies not older than 10 years in full text, 10 publications in English were chosen and used in the review. The risk of bias was assessed using the Cochrane risk of bias tool. And now I will discuss the results. So VAS pain scale value in painful areas decreased in 3.65 points while applying photobiomodulation therapy on TMD patients using a gallium aluminum arsenide laser when energy density is 105 joules in cubic centimeter. Photobiomodulation significantly reduces pain by palpating the TMJ area. Photobiomodulation significantly increases maximum values of the mouth opening amplitude. By comparing non-painful values of mouth opening in placebo and photobiomodulation groups, significant differences were not found. Differences between pain values were also not found by comparing the efficiencies of photobiomodulation and occlusal splint. A significantly better infrared radiation impact is noticed in VAS values in two studies, which assess photobiomodulation's efficiency with infrared when wavelength is 790 nanometers and red when wavelength is 660 nanometers radiations 180 days after the last intervention. And now I would like to conclude everything. So firstly, photobiomodulation increases maximum mouth opening. Secondly, photobiomodulation and placebo evenly increase maximum mouth opening. Then photobiomodulation and occlusal splint reduce pain evenly. And finally, infrared laser radiation more effectively reduces pain than red laser radiation. So this is the end of my presentation. In the slide you can see references. And now you can ask me some questions related to this topic.
Okay, so thank you for your presentation. Does the jury have questions?
Thank you for the presentation. And my question was, what was your personal inputs in the study? What you performed in the study?
Well, me and my colleague shared the work like half and half. So we just do research, then we collect all those articles and share half, I don't know. Yeah, and we, and that's it.
Okay, thank you.
Can I ask also?
Oh, yeah. Sorry.
I don't need it. Voice is quiet. I want to ask you, what kind of temporomandibular joint disorders you include in your studies? Because we know that there are quite a lot. You told us.
Yeah.
And, but different treatment methods and different influence of those methods, even though photomodulation in different kind of temporomandibular joint disorders?
Yeah,
All of them.
well, photobiomodulation helps to reduce pain, and it wasn't exactly separated which kind of disorder it helps, just pain related to temporomandibular joint area. And I know in those studies there was no, not separated, not differentiated the types of disorders that for those photobiomodulation could help. So,
Hello, thank you for presentation. I would like to ask one question. You mentioned about Wasp scale. So can you explain, because there are two ways of evaluating pain. So the score which was used for the Wasp pain was it from 0 to 10?
Yeah.
Or from 0 to 100?
no,
Which scale
from
was
0
used?
to 10.
And you got the result 3.65?
Yeah.
Because there are no results as comma, I mean 1.5. You can only evaluate 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Yeah.
And the
But the average,
average 365. And the amount that was used, I mean, for how many patients?
it wasn't results from a few studies, so
And they all used the same scale,
yeah.
from 0 to 10?
Yeah.
Okay, thank you.
Thank you for your questions. Thank you once again for your presentation. Now, I would like to invite the next presenter, Mariam Varanetskaite, with the abstract topic, Evaluation of Post-Operative Pain and Discomfort in Patients Undergoing Surgical Exposure of Impacted Maxillary Canines.
Hello, my name is Mariam Varanetskaite and I'm representing Lithuanian University of Health Sciences. And today I will present the topic, Evaluation of Postoperative Pain and Discomfort in Patients Undergoing Surgical Exposure of Impacted Maxillary Canines. Why this topic is important? It is important because in orthodontic practices, impacted maxillary canines are quite frequent, with up to 23.5% of cases. Usually, a combined surgical orthodontic treatment is used to resolve this condition when the tooth is surgically exposed, and an attachment is used to direct the tooth to occlusion with fixed orthodontic appliances. However, this treatment causes discomfort and postoperative pain. Therefore, it is important to inform patients about the procedure. The aim of our study was to evaluate pain and discomfort related to surgical exposure of impacted maxillary canines. And we obtained a permit from the Bioethics Center of Lithuanian University of Health Sciences to perform this retrospective study. And the data of 25 patients, which included 17 female and 8 male, with a mean age of 15, were treated with combined surgical orthodontic approach, and we analyzed the data retrospectively. And the data was obtained from pre-treatment cone beam computed tomography and discomfort of evaluation questionnaire, which was based on the previous studies. The questions included level of discomfort during surgery from 0 to 10, where 0 is the lowest. Also level of pain in the evening, level of pain 1, 2, and a week after, 2 days after surgery, and a week after surgery. Cone beam computed tomography analysis consisted of evaluation of impacted maxillary canine mesiodistal inclination, horizontal, vertical dislocation from alveolar process edge, labia palatal localization, and length of impacted maxillary canine eruption path. In the picture on the left side, you can see the sectors of mesiodistal crown position of impacted maxillary canine. In the first one, the position of incisive cusp corresponds to the position of deciduous absent canine. The second is localized between the distal part and the midline of the lateral incisor. The third one is localized between the mesial part and the midline of lateral incisor, and the fourth one is localized between the distal part and the midline of central incisor. And finally, the fifth one is localized between the mesial part and the midline of central incisor. And in the picture on the right side, it describes eruption path length calculation, and it was measured as the distance between the actual crown tip and the predicted correct position of the crown. For statistical analysis, IBM SPSS statistics software was used, and to carry out our research objectives, the coefficients that we used were a non-parametric Spearman correlation coefficient, Mann-Whitney U-test, intra-class correlation coefficient, Cohen-Kappa coefficient, and value of p0 less than 0.05 was considered statistically significant. In this table, you can see the average discomfort during surgery and postoperative pain levels during recovery. And pain level differs statistically significantly between different days. And in addition, the pain after the procedure was not statistically significantly related to the age or the gender of the patient. Here you can see the comparison of discomfort during surgery and postoperative pain experienced by the patients in labial and palatal impacted maxillary canine localization groups. And the level of discomfort during the procedure did not differ significantly in the labial and palatal impacted maxillary canine groups, with a mean scores of 3.5 and 2.6 respectively. In addition, neither labial or palatal location, nor the impacted maxillary canine impaction being unilateral or bilateral, had any effect on the level of pain during different stages of measuring. And in this table, you can see the mean values of mesial inclination, impaction depth, height, and eruption path length in the palatal and labial groups. And impaction height, depth, eruption path length, and impacted maxillary canine inclination were not statistically significantly related to the discomfort and pain. And to conclude, pain in the evening after the intervention was rated the highest and decreased over time, but there was no significant correlation between the discomfort and the location of the impacted tooth. And patients' gender or age did not have any impact on discomfort and pain. So that is the end of my presentation. If you have any questions, you could ask.
Okay, thank you for your presentation. Now, question to the jury. Do you have any questions?
Thank you for presentation. I want to ask you first about questionnaire. You said that it is from previous studies. What previous studies?
There were previous studies that studied the pain and discomfort after exposure of impacted maxillary canines. However, they studied not the location of the impacted maxillary canine, however, the two eruption techniques. And they created questionnaires which asked patients how they felt, and we created these.
So these questionnaires, you created them, or they are?
We created it, but it was based, we based it on the other studies.
Mm-hmm. Okay. Now I saw these results. Can you go back to the conclusions? There was no significant relation between discomfort and the location, but I saw that the discomfort more in labial position and pain more in palatal. If we can go back to the pain back here.
Yes, but it was not statistically significant.
But
yes, as you can see in the third column, the p-values are described. So.
Oh. Thank you.
Thank you, Mariam, for the question. My question, when was the surgery performed?
It was performed in 2021 because we did a retrospective study. There was a prospective study about it, and then we studied everything.
So,
actively.
as I understood, all patients were given the questionnaires.
Yes.
And you said that you prepared that questionnaire.
We didn't prepare it. Our supervisor prepared it because she wanted to do a prospective study, and then we also took the data and performed it retrospectively.
So what was your input, your personal input, what you did in the study?
I summed up the results, and we also had to measure the localization of the impact.
From the
PNIs.
CBCTs?
Yes.
But you haven't seen those patients.
No, we haven't seen them directly.
Okay, thank you.
Thank you for presentation. I would like to ask about protocol of the work. When you talk about pain evaluation, was there no protocol, such procedure that all patients were given the same painkillers? And I mean, had they were instructed how to use them, or they could use it randomly? Because when we evaluate pain, someone
Yeah.
could take 1 tablet, someone could take 5 tablets, so it's very difficult to evaluate in these cases.
Yes, the amount and the amount of painkillers that the patients took was also evaluated. However, we did not take it in this abstract because we wrote an article about it, and then we took it into account, painkillers also.
So you actually believe by the words, by the patient themselves, I mean?
Yes.
Okay.
They wrote how much painkiller they used, and they were prescribed and told how to use it according to their pain levels.
And may I ask which painkiller have you prescribed?
Ibuprofen, but it was like different dosages also.
So for one was 400 milligrams,
Yes.
for others was 600 milligrams?
Yes.
Okay, thank you.
Thank you for your presentation once again. Now I would like to invite Justina Šikšnelytė, who present a topic, relationship between orthodontic treatment of class 2 and temporomandibular disorders, a systematic review.
Good morning, everyone. So I'm Justina Šikšnelytė from the 5 course of odontology, and the topic that I'm going to present today is relationship between orthodontic treatment of class 2 and temporomandibular disorders. And the type of a study was a systematic review. Temporomandibular disorders is a complex of diseases with multifactorial etiology involving the disorders of the masticatory muscles and or temporomandibular joint. And these disorders affect approximately from 2 to 8% of adult men and from 4 to 15% of adult women, as well as up to 7% of adolescents. And TMD can manifest as limited mandibular movements and mouth opening, as well as joint clicking or locking, and painful symptoms such as soreness located in the masticatory muscles, preauricular area, and or temporomandibular joint. Talking about the etiology of TMD, the main risk factors are thought to be systemic diseases, also traumas of the orofacial region or spine, inheritance, gender, age, parafunctions, as well as stress and depression. And probably one of the most debated one is orthodontic treatment. However, the results of numerous clinical trials evaluating the relationship between orthodontic treatment and TMD are different and demanding a thorough investigation. Therefore, the aim of a systematic review was to evaluate the influence of class 2 orthodontic treatment with fixed appliances on temporomandibular disorders. Class 2 was chosen as it is probably one of the most common malocclusions, and its treatment using fixed appliances usually involves the Herbst appliance and or braces. The systematic review was conducted in compliance with PRISMA requirements. An electronic search using keywords orthodontic treatment and temporomandibular joint disorders was carried out on December 15 in 6 electronic databases. And the inclusion criteria were research articles published less than 10 years ago, written in English, and evaluating the influence of class 2 orthodontic treatment with fixed appliances on the development of the signs and symptoms of TMD, or on the improvement of the symptoms. And the studies, they excluded if the subjects of the studies had craniofacial syndromes, cleft lip and or palate, previous trauma for orofacial region or spine, systemic arthritic and muscular diseases, as well as skeletal asymmetries, orthodontic surgery. And the studies that did not include the subjects with class 2 malocclusion were excluded as well. As you can see in the Prisma flow diagram, the 1,370 articles were initially found, and full text of 46 articles were read and assessed for eligibility, and 5 of the articles were included in the systematic review. 3 of them were cohort studies, and 2 were cross-sectional studies. The quality of the studies was evaluated using Joanna Briggs Institute's critical appraisal checklist for cohort studies and cross-sectional studies, and cohort studies were evaluated as having low or medium risk of bias, and the cross-sectional studies as having low risk of bias. 2 of the studies divided the subjects to control and orthodontic treatment groups, and the patients treated orthodontically were treated using fixed appliances, as I mentioned before, which were brackets and Herbst appliance, and one of the studies did not mention what type of fixed appliances was used. The subjects were adolescents and adults, and all of the studies examined TMD clinically. In addition, the subjects of all studies had to answer a questionnaire related to the symptoms we have experienced of TMD. And the research diagnostic criteria for temporomandibular disorders was used as a standardized protocol for clinical examination and questionnaires. RDC TMD is a set of instruments used for diagnosing the 3 main groups of TMD, such as the muscle disorders, the TMG disc displacements, and other common TMG-related disorders such as arthralgia, osteoarthritis, or osteoarthrosis. And now turning to the results, one cohort study found that TMD symptoms increased during the orthodontic treatment. However, the symptoms relieved upon completion of the treatment, and there was an actual improvement in myofascial pain after orthodontic treatment. The 3 other studies stated that there was no statistically significant association between TMD and orthodontics, despite the fact that the follow-up terms were different, ranging from 1 month after the treatment was began, and to more than 15 years after the treatment was over. And one of the cross-sectional studies comparing orthodontic treatment and control groups stated that TMD symptoms were observed at a similar frequency in both groups, and that the subjects of orthodontic and control groups did not differ significantly according to TMD symptoms. The systematic analysis was not performed, unfortunately, due to a high heterogeneity of the studies. And to conclude, the symptoms of temporomandibular disorders manifested during orthodontic treatment. Nevertheless, we resolved upon completion of the treatment, and there is no significant evidence that class 2 orthodontic treatment with fixed appliances is a predisposing factor for TMD. However, the symptoms of TMD might be improved during orthodontic treatment. And more high-quality clinical trials are needed in order to gain more evidence and to prove this relationship. So thank you for your attention.
Thank you for your presentation. Now I would like to ask the jury, do you have any questions?
Yeah, I would like to ask you.
Please speak in the microphone because our online listeners can hear you.
Thank you for a nice presentation. Do I correctly understand that in all this research, CT scan wasn't used? I mean that to determine the condyle position in fossa before treatment, after treatment?
One study mentioned that after treatment, the MRI was used, but this was only one study of 4.
Thank you.
Any questions more? Okay, thank you for your presentation. Now, I would like to invite other presenter, Raimonda Gontulytė, who presents the abstract of efficacy of conservative treatment of peri-implantitis, a systematic review.
Hello, my name is Raimonda Gontulytė, and I am a 5-year odontology student. And I will present the efficacy of conservative treatment of peri-implantitis. This is a systematic review. And in recent times, implants have been widely used to treat partial or complete defects of dental arch. Despite high long-term survival rates of dental implants that seek about 95%, peri-implant diseases present as the most common complication in implantology. The prevalence of peri-implantitis is about 21%. Peri-implantitis is a plaque-associated pathological condition occurring in tissues around dental implants, characterized by inflammation in the peri-implant mucosa and subsequent progressive loss of supporting bone. Not treated peri-implantitis may ultimately lead to loss of implant. The treatment of peri-implantitis is difficult and the outcome varies. The primary treatment is conservative. It includes some gingival debridement with carets, ultrasonic devices, or via air abrasion. Additionally, probiotics, antibiotics, or local anti-infective therapy can be added. Over the past decades, a variety of these interventions, alone or in combination, has been investigated. But currently it remains unclear which of non-surgical methods are the most effective for the management of peri-implantitis. Therefore, the aim of the systematic review was to evaluate the efficacy of conservative treatment methods of peri-implantitis. And talking about the methods, comprehensive electronic database search was carried out in compliance with PRISMA. The inclusion criteria were research articles published less than 5 years ago, written in English. The follow-up must have been up to 6 months at least. The treatment outcomes had to include changes in probing depth and or bleeding on probing and or radiologic marginal bone level. The results, 6 studies was included in this. I didn't mention that the quality of all included studies was assessed by the Cochrane collaboration tool. ROP2 for randomized studies. And talking about the results, 6 studies were included in this review. One study was classified as having a high risk. The remaining 5 studies had a low risk of bias, and the results are presented in the table. No significant difference in probing depth and bleeding on probing changes was found between the additional combination of metronidazole plus amoxicillin and non-surgical debridement alone. The other study states that the additional systemic metronidazole significantly reduced probing depth and increased marginal radiographic marginal bone level more than non-surgical debridement alone. And this difference in these results between these 2 studies may occur because of the diverse severity of peri-implantitis. No significant difference in probing depth and bleeding on probing changes was found between Veg-Junk probiotics and non-surgical debridement alone. And the additional insertion of chlorhexidine digluconate chips reduced probing depth significantly more compared to non-surgical debridement alone. Non-surgical debridement with additional use of desiccant material, Hibernix, reduced probing depth more than the adjunct glycine powder. And Hibernix is a chemical gel applied topically. It helps to remove bacterial biofilm. And the last study examined air polishing with erythritol and ultrasonic therapy. Both treatment methods improve clinical parameters, but they were not statistically significant. Also, no significant difference between these two treatments was found. And to conclude, the additional desiccant material was more effective than the adjunct glycine powder to compare with probing depth. The adjunct systemic metronidazole or chlorhexidine chips were more efficient than non-surgical debridement alone. The erythritol air polishing was as limited in effectiveness as an ultrasonic scaling, and no additional effects have been observed using lactobacillus rotary probiotics or systemic metronidazole and amoxicillin in combination with non-surgical debridement. And thank you for your attention.
Thank you for your presentation. Now, Darjee, do you have any questions?
Oh, thank you for presentation. So I want to ask such a question. There was some information in these articles about evaluation of daily hygiene procedures of these patients or methods like irrigation or something else during the treatment, before treatment and during the treatment.
About what information?
About oral hygiene methods and oral hygiene, how it was, and during treatment it was.
Yes, it was.
It was the same methods of the hygiene or not, or they didn't evaluate that.
The oral hygiene between that 6 studies wasn't equal, and it is that studies maybe limitation that every person have every person oral hygiene is just unequal, and it can be equal. And if you ask about supportive treatment after main treatment, it was sport therapy included subgingival debridement every 3 months, and before every procedure was professional oral hygiene done. I don't know if you understand.
It wasn't paying big attention to oral hygiene.
No, it was. It was so that just patients they should.
Yeah, for sure, but they compare these patients or not about the hygiene. Because it's in the chain. Do all the patients in these studies, they have the same oral hygiene?
Not the same, but similar.
Any more questions? So thank you once again for your presentation. Now I would like to invite the presenter Mariam Voroneckaitė to present the abstract impact of pathologic tooth migration on oral health-related quality of life in adult subjects with periodontitis, a systematic review.
So, hello again. Now I will present the topic of impact of pathologic tooth migration on oral health-related quality of life in adult subjects with periodontitis. Periodontitis is known as one of the most frequent oral diseases, and its prevalence could be up to 40% of the adult population. As the inflammation progresses, it leads to periodontal attachment loss, which could result in pathologic tooth migration and tooth mobility, as well as compromised smile aesthetics. All of them have an impact on physical and psychosocial well-being. The aim of our study was to assess the current evidence on the relationship between the pathologic tooth migration and oral health-related quality of life in subjects with periodontitis. The review was performed according to PRISMA guidelines, and we used the databases of PubMed, ResearchGate, the Cochrane, and the ScienceDirect to carry out the search. And keywords that we used were periodontitis, oral health-related quality of life, pathologic tooth migration, tooth mobility, and clinical attachment loss. We included studies in English language analyzing oral health impact profile, or oral health-related quality of life of adult patients with periodontitis, tooth mobility, and pathologic tooth migration. Case series and reports, systematic reviews, and pilot studies were excluded from the search, and in addition, manual searches and reference links were used to supplement the search. In order to assess the quality and the risk of bias of selected studies, Access tool was used. Here you can see the graphic depiction of evaluation of the studies using Access tools. And as you can see, the answer yes ranged from 65 to 80% in the selected studies. Our primary research yielded 49 articles, and after checking the titles for relevancy, and 11 articles were selected for the full text analysis. And after applying selection criteria, 6 studies were included in the systematic review with a total number of 1,312 patients with periodontitis. The overall quality of the studies was good, and 5 of them invested the effect of different forms of periodontitis on oral health-related quality of life. There were 4 articles that demonstrated a statistical significance between severe periodontal attachment loss and lower oral health-related quality of life results. However, there was a study that proved that oral health-related quality of life depends on periodontitis, but the severity of this disease does not have an impact on patients' quality of life. Tooth mobility was also displayed as a factor that affects oral health-related quality of life the most, especially the psychological factor. And to conclude, it is important to note that there is a lack of evidence on the impact of tooth mobility and pathologic tooth migration on oral health-related quality of life. However, according to the current literature, periodontal disease is linked with poorer oral health-related quality of life. However, factors which affect it are still unclear and should be further analyzed. And this is the end of my presentation, and here you can see the references.
Thank you for your presentation. Now, Dr. Lee, do you have any questions?
Thank you for presentation. I would like to ask one question. When you make actually the literature reviews, you should actually put a very precise period of time which you're going to examine, because right now we have some articles from 2006, which are 16 years old, and others is from 2021. So you should actually minimize, if it's possible, by
but
until
the
5 years.
studies included in the systematic review were not older than 10 years.
Not older than 10 years, so 2006, how is that possible?
2006, it probably was used not for the systematic review, but for introduction and other
Okay.
reasons.
Can you show that actually?
What?
Please show the slide where you can...
Where I use the,
Yeah, the articles.
there, here, yes.
There's 31. And the
Yeah,
last one,
yes.
the last one is 2013. So we
Yeah,
see-
so the one study I was
Next slide
included.
is excluded.
Okay.
And thank you for the presentation. What was your personal input into that study?
Me and my partner, we share the work 50-50, and we both did the database search with different keywords to yield the maximum number of articles. And we
The
summed up
different keywords.
with
What do you
the,
mean?
with the keywords that we used here that I
Okay,
showed.
so you say that you used several keywords and your partner used another.
No, we use the keywords. However, we also supplemented the search using external links and reference links, and that's how we came up with the final number of articles that we could include.
And
So
if you argued about the article to take into the review or not, how you...
we asked our supervisor if it was usable in the.
So you made a review separately and your colleague made separately?
Yes, and then we compared our results
Okay,
together.
thank you.
Any more questions? Okay, thank you once again for your presentation. Now, we will have an online presentation. The presenter will be Yulia Chek with the abstract called Blood Type and Dental Status.
Dear members of the jury, conference participant, and everyone present, we offer you the result of the study Blood Type and Dental States. Dental health is a mirror of the state and general health of the body and is integral to it. Dental caries and inflammatory periodontal disease are the most common dental pathology. 97% of the population of Ukraine suffer from this disease. Dental states of the patient in complex and multi-component concept of combination and states of teeth and dentition, oral hygienic states, periodontal condition, and states of oral mucosa. The parameters of dental states can be influenced by many factors such as unhealthy eating, smoking, alcohol abuse, or oral hygienic, but some of which are genetically determined. Some scientists and research have begun to study the correlation between disease of different body system and blood type. For example, people with the first blood group were found to be less likely to develop pancreatic cancer, while people with the second blood group were at increased risk with developing stomach cancer. A study of correlation between blood type and severity of gingivitis in South Canara found the following. The percentage distribution of subjects with the first and the fourth blood group was more in healthy gingivitis group and several gingivitis group, while subjects with the second and the third blood group were more in periodontal group. There was increased prevalence of the subject with the first and the fourth blood group with the healthy periodontium, while subject with the blood group of number second and the third showed increation toward disease periodontium. Identifying connection between parameters and antigens of the blood group according to AB0 system in a certain population in the future allows to identify high-risk group and increase the effectiveness of primary preservation of dental disorders. The aim of our work is the study to the connection between indicators of dental states and blood type of respondent according to AB0 blood system. As a method of analysis, synthesis, systematization of actual material, discourse analysis was used in research. 34 young people aged 20 to 27 who are graduates of Poltava State Medical University took part in this research. All study participants were examined with the determination of the hygienic index by green vermilion, the prevalence and intensity of caries, papilla marginal alveolaris index of PMA. Blood type was recorded on the AB0 system during the patient history gathering. The majority of participants in the study, namely 17 people, had the second blood type. 26.5% note that they had the first blood group, and people with the third and the fourth blood group were only 11.8%. The respondent with the second blood group had a significantly worse of the hygienic index by Green million compared with people with the other blood group. The participants with the first, the third, and the fourth blood group were characterized by oral hygienic states, which did not differ significantly in numerical respectation. In this chart, you can see the distribution by blood type and number of respondents with periodontal tissue lesions in each group. The prevalence and intensity of carious lesion in the subject did not differ significantly in respondents with different blood group. Among the respondents with the blood type, the first and the second blood types, persons with periodontal disease and healthy periodontal tissue were approximately helped. 75% of respondents with the third blood type found various forms of periodontal tissue damage. Respondents with the fourth blood type had the lowest number of people with periodontal disease. As a result of the study may indicate the connection between the indicators of dental states and blood type of respondent according to AB0 system. The update research results require further detailed study and comprehensive analysis. Attentive attitude of the organism, observance of oral hygienic regime, regular inspection of the dentist and therapist are the main ways of the healthy preservation. Thank you for your attention, and I'd like to ask every participant to pray for peace in Ukraine, as prayer is a cure for a confused mind, a weary soul, and a broken heart. Thank you very much.
Do you have any questions to the presenter?
Hello, thank you for presentation. Should I look there?
I don't know, I guess.
Thank you for presentation. One of your points is that study participants with second, third, and fourth blood groups were categorized by oral hygiene, and what about the first group? And secondly, I think that there should be some changes in mathematical region, because when you add all the percentage, you get 100.1%. So this is just a small note. For next time, please look up the numbers, okay? Because they don't add up.
Okay, thank you. I will correct it.
Any more questions? Okay, thank you once again for your presentation. Now I would like to invite the next presenter, Gerda Kilinskaitė, with the abstract named Comparison of the Expression of Ki-67 Marker in Ameloblastoma and Odontogenic Keratocyst, a Systematic Literature Review.
So, good morning, everyone. I hope all of you are doing well today. My name is Gerda Kilinskaitė, and today I'm going to present comparison of the expression of Ki-67 marker in ameloblastoma and odontogenic keratocyst. So first of all, I want to say thank you for my scientific work colleague Reda Vaičiūnaitė and our supervisor doctoral degree Jan Pavel Rokitski. I really appreciate our hard work, and I'm happy to start this presentation in International Health Sciences Conference. To begin with, the development of odontogenic keratocysts and ameloblastoma are associated with incorrect adhesion of molecules, proliferation of cells, angiogenesis, and osteolysis. Ki67 is a proliferation marker, in other words, nuclear non-histone protein, used in diagnosis and prognosis of pathological lesions, mainly in human tumors. This marker is expressed in cells at different times of cell cycle and helps to assess the progression and aggressive potential of lesions, mostly by measuring cell proliferation index pi, which is a prognostic marker and is evaluated by using histochemistry by counting cells with positive expression. Ki67 marker differences of proliferative activity in odontogenic keratocyst and ameloblastoma are considered because it could play a role in biological aggressive behavior. And the aim of the study is to compare the proliferation index in ameloblastoma and odontogenic keratocyst in order to find out which lesion has a higher potential for aggression. Moving to the methods, our systematic literature review was conducted in 4 electronic databases, which were PubMed, Wiley's online library, the Cochrane library, and ScienceDirect. This review was performed according to the PRISMA statement by using keywords such as ameloblastoma, odontogenic tumor, odontogenic keratocyst, and immunohistochemical markers. And the inclusion criteria were human clinical trials and English language. And we excluded studies published older than 10 years, systematic reviews, and case reports. According to the PICO schema, the study included prospective trials in which adult patients diagnosed with ameloblastoma or odontogenic keratocyst, which immunohistochemical expression of Ki67 were investigated in different lesions in order to evaluate the aggressive potential of lesions. In total, 4,014 publications were initially identified in the electronic databases, and after the final screening of 42 full texts, 5 studies were included in the final evaluation. And moving to the results, in studies comparing the amount of positive cells between ameloblastoma and odontogenic keratocysts, were observed that positive cells was found more in odontogenic keratocysts from 11.57% to 46.4% in 2 studies. This result can confirm a study which observed a statistical significant difference between the pi range of ameloblastoma and odontogenic keratocyst. Other authors also show that the proliferation index also was higher in odontogenic keratocyst than in ameloblastoma by 25.1%. Although the rate of pi was considerably lower in other study, there was also a statistical difference between ameloblastoma and odontogenic keratocyst immunostaining by 4.1%. The pi was very different in all studies, but can be concluded that the expression of the Ki67 marker was statistically significantly higher in odontogenic keratocyst than in ameloblastoma, which causes biological aggressive behavior, and the p was less than 0.05. And to sum everything up, the higher the proliferation index was found in odontogenic keratocyst than in ameloblastoma, and the higher expression of the Ki67 marker of odontogenic keratocyst highlights more aggressive behavior of these cystic lesions. And here you can see our references, and thank you very much for your attention.
Thank you for your presentation. Now, Jerry, do you have any questions?
Hello. Thank you for the nice presentation. I would like to ask, did you count how many cases from all those articles were?
Actually, this time, no. We just compare those pi ranges, cell proliferation index, just with percentages.
Hello.
Hello.
Thank you for presentation. It was interesting why in the keywords was not included the Ki67 marker board.
I'm sorry, you're asking why we chose this topic, or?
No. Why in keywords didn't include the Ki67 marker, the board?
Yeah, because it didn't work, so we were checking more than Ki67 markers to find out. those publications, so that's why.
Thank you.
You see how it's interesting. And why Ki67? Is this the only marker that shows the aggressive behavior?
It is not the only, but we chose to present Ki67 because maybe due to lack of symbols, and we left other markers of who shows pathological lesions for bigger researchers, maybe for meta-analysis.
Okay, thank you. And what do you think, what could be the maybe practical recommendations so to search for such a markers in every clinical case?
Actually, Ki67 is more used to find the cancer, tumors, so maybe there could be used more, and in ameloblastomas and odontogenic keratocysts too.
Could we, I'm endodontologist, could we divide or diagnose clinically ameloblastoma or keratocyst?
Actually, yes, with an oral surgery experts.
Okay, but from what? From radiological?
Yeah, from radiology and anamnesis.
Okay, thank you.
Any more questions? Okay. Thank you once again for your presentation.
Thank you.
Now, I would like, for the third time, invite the presenter Mariam Voroneckaitė with the topic Association between Apical Periodontitis and Root Canal Treatment in Patients with Type 2 Diabetes, Systematic Review.
Okay, so for my last but definitely not least presentation, I will present the association between apical periodontitis and root canal treatment in patients with type 2 diabetes. And this abstract was prepared by me, my colleague Karolina Budreikaitė, and Daniela Oleinikaitė. Type 2 diabetes mellitus is an endocrine disease which affects over 6% of world population. Sustained hyperglycemia plays a role in inhibited healing and chronic inflammation, and that could lead to complications after root canal treatment, such as apical periodontitis. Therefore, dentists should evaluate the diabetic patients thoroughly. It includes not only oral conditions, but also glycemic control status to treat infections accordingly. The aim of our study was to evaluate the relationship between apical periodontitis and root canal treatment in patients with type 2 diabetes. The systematic review adhered to PRISMA guidelines, and we used databases of PubMed, ScienceDirect, and the Cochrane Library to carry out the search. Diabetes, periodontitis, and root canal were used as search terms, and we included studies in English, not older than 10 years, which studied adult patients with type 2 diabetes mellitus after root canal treatment. Case reports, systematic reviews, meta-analysis, and animal studies were excluded from the search. Our primary database search yielded 313 results, and after thoroughly checking the content for relevance of the articles, we finally selected 4 studies, and they had a total of 15,810 patients. 3 out of 4 studies concluded that there is a significant link between apical periodontitis after endodontic treatment and type 2 diabetes mellitus. However, 1 study failed to confirm the results from other 3 studies. As for glycemic control, 2 studies found similar results. Yip and others investigated glycemia control on the outcome of root canal treatment and concluded that there is a significant association between apical periodontitis and poor glycemia control. In addition, Sisley and others also found that in poorly controlled type 2 diabetes mellitus group, Periapical lesions were statistically significantly more frequent than in well-controlled type 2 diabetes mellitus group. And to sum up, there is a statistically significant relationship between type 2 diabetes mellitus patients and the occurrence of apical periodontitis. And it is also important to note that glycemic control and post-treatment apical periodontitis are statistically significantly related, and this information could be of great use in managing patients with type 2 diabetes mellitus. And this is the end of my presentation. If you have any questions, you're welcome to ask.
Thank you very much for your presentation. Now,
Hi, Mariam. Thank you for the presentation. Who was your supervisor?
Daniela Olejnikaitė.
She's a postgraduate student.
She's a resident, yeah.
What is the novelty of your study?
Can you ask again?
The novelty of the study.
Well,
What you found out new?
that it is important to know the anamnesis, the full anamnesis of the patient, not only related to dental diseases, but also systemic diseases. For example, diabetes could have an impact on.
Yes, but do you agree that the relationship with apical periodontitis and there is nothing with the diabetes? It's just about the control
Yes.
of
yes,
the disease, so nothing with the diabetes. And as we know, today's the diabetes is well controlled. So, and if it's poorly controlled, so you can't say that apical periodontitis, it's more evident in the diabetes disease.
Yeah, but however, there were studies that found that the control, they found that apical periodontitis had a significant relationship with diabetes as well, not only the control. So
But it's mostly with the control.
yeah,
nowadays.
mostly it is with the control.
Thank you.
any more questions? Thank you once again for your presentation. And for the last presentation, I would like to invite Ignas Mickevičius with an abstract called The Incidence of Complications After Replanting Avulsed Permanent Teeth.
Dear colleagues, professors, first of all, I'd like to thank my co-author for helping with this article and my supervisor, Marius Leketos, and also the Students' Scientific Society for helping to organize such a well-conducted event for us to share the ideas and learn something from each other. So I feel the privilege to close this session with my systematic literature review about the incidence of complications after replanting permanent teeth. So why is it relevant? Avulsion accounts up to 16% of all dental injuries according to global etiological studies. The prognosis depends on the actions taken place of the incidence and promptly after the avulsion. Replantation remains the treatment of choice but cannot always be carried out immediately. Delayed replantation leads to complications. It is also relevant due to the rising popularity of electronic scooters and motor sports and water sports. So the aim of this study was to determine the incidence of complications after replanting avulsed permanent teeth under varying conditions. Methods were used was electronic search according to PRISMA guidelines. The databases used was PubMed, ResearchGate, and Google Scholar. And the keywords that was used was dental trauma, avulsion, root resorption, ankylosis, total luxation, complications, and replantation. A focus question formed on PICO was formed. What is the incidence of complication after replantation of permanent teeth for patients who suffered avulsion under varying conditions such as transport mediums, extraoral time, stage of root development? So only full-text articles, retrospective cohort studies, and randomized controlled clinical trials from the year 2012 to 2022 were included. Systematic reviews, meta-analysis, case reports, in vitro studies, and animal studies were excluded. The risk of bias was assessed using two tools: GBI critical appraisal tool for retrospective cohort studies, and Cochrane risk of bias tool for randomized controlled trials. A total of 220 articles were found, 14 were selected for full text analysis, and 9 fit the final inclusion criteria. 8 out of 9 were retrospective cohort studies. That's why Johannes Briggs Institute tool was used for answers. Not applicable was the answer to the first 2 questions for all studies regarding the selection of a population because no control group was included. Yes to the following 8 questions related to research intervention, follow-up, and statistical analysis, rating studies low in risk in regards of bias. Risk of bias was apparent because in all studies, the subjects were aware of the intervention being performed on them and expected a positive result after replantation. So one study was assessed with a ROB2 assessment tool, and 3 out of 5 domains were low in risk, and 2 of them were of some concern, which puts the overall study of some concerns in regards to bias. So talking about the results, delayed replantation has a poor long-term prognosis. After replantation of the tooth, various complications can occur: ankylosis, pulp necrosis, inflammatory external root resorption, and replacement resorption. 7 out of 8 studies that included mature teeth replantation reported pulp necrosis followed by endodontic treatment. Advanced root development stages in teeth with immature roots were also a strong predictor of pulp necrosis. Immature root development showed significantly less pulp necrosis compared to teeth with full root formation. The p-value was below 0.05. All studies indicate from around 17 to 58% incidence of replacement resorption, from around 23 to 37% of inflammatory external root resorption, and from around 8 to 66% of ankylosis after replantation. Dry time before replantation varied greatly in each study, from 5 minutes to 7 days, with standard deviations of 82 to 151 minutes, which is also a limitation of the study that I did. Other limitations that were included in this study was the amount of time, the splinting duration, and the endodontic treatment time, when it was done, and so on. Storage medium was significant for the development of ankylosis-related resorption and only root development for pulp necrosis. The incidence of periodontal ligament necrosis of replanted teeth stored in physiological medium in one study was 61%, which was significantly lower than that of replanted teeth stored in non-physiological mediums. So to conclude, the incidence of complications such as pulp necrosis, ankylosis, inflammatory external root resorption, and replacement resorption depend on extraoral time, transport medium, and maturity of the root. The longer a tooth is kept outside, the more periodontal tissue is damaged irreversibly. Treatment of dental avulsions is usually delayed, which explains the occurrence of pulpal and periodontal complications. This is the end of my presentation. Any questions?
Thank you very much for your presentation. Now, Darshri, do you have any questions?
Yes. Thank you for the presentation. And you said that storage medium was significant for development of ankylosis-related resorption. What kind of storage?
So the 3 storages that were included in all of the studies were milk, saliva, and water. So the most prominent one was milk, as said in international trauma guidelines.
But what do you mean? It was significant for development of ankylosis?
Could you repeat the question?
storage medium was significant for development of ankylosis-related
Okay.
resorption. Can you
understand.
explain, please?
So for mediums such as water, and if no medium was used, there was a higher prevalence of resorption after replantation, and those that were stored in milk and physiological mediums were lower in risk of developing resorption.
So what medium do you suggest to
Milk.
store? Milk.
Yeah.
And the extra oral time, what is the best?
So the quicker you get to replant the teeth,
What do you mean the quicker? How long the...
Okay, so up to 5 minutes. After 5 minutes, the periodontal tissues start to be damaged, and up to if the replantation takes time after 60 minutes, the periodontal tissues are damaged irreversibly.
Periodontal cells, you mean, on the root surface. So it's 20 minutes they could be alive.
Okay.
Yeah, so this is the period, but nevertheless we have to keep into the storage medium.
Yes.
Thank you.
Thank you for presentation. Can you tell me how it is that after avulsion we have not 100% pulp necrosis?
So 100% of a pulp necrosis happens when the apex is closed. If the maturity of a tooth is fully developed, pulp necrosis happens almost all the time. And there is a chance of pulpal, I don't know, I would say it, pulpal regeneration, that's the word, happening if the root is not fully closed. But even then, some complications can occur and pulp necrosis happens most of the time. So endodontic treatment is necessary. No. No.
You were talking about immature?
Permanent teeth.
Of course permanent, but immature. I mean, they're not closed apex.
No. With like not fully immature, but close to maturity.
So when you will do the endodontic treatment after avulsion?
When it's permanently closed.
Okay, and what about immature teeth?
No, not all the time.
And when?
My topic wasn't on endodontic treatment, so I cannot really explain.
The last, and we have time.
Okay, sorry.
Okay, thank you for your presentation once again. I would like to thank to all the presenters for their delightful presentations. Now let's take a 7-minute break while all the scores are counted. Right after the break, we will announce the winner. And in the meantime, I would like to thank for jury for your time, for your work today. And we have a little gifts for you for your work. So thank you once again for Association Professor Marius Lekatas. Okay. Also, we would like to thank for Association Professor Greta Lodiania. We would like to thank for Professor Gediminas Jakonis. Also, we would like to thank for Professor Dainius Razikevičius. And we would like to thank for Jan Pavel Rakitsky. Now we have a few minutes break till the results are counted, so we could talk with each other and have a little time till the results came back. Gerai. Veikia, neveikia? Veikia. Gerai. So we are back here, and after counting out all the jury results, we have the winner. And the winner of this session is... Okay. Justina Šikšnelytė, Raimonda Guntulytė, Kristina Lopatelė, and the topic is relationship between orthodontic treatment of class 2 and temporomandibular disorders, a systematic review. So you can come here for... So the odontology and maxillofacial surgery session has finished. I would like to thank to all the participants for attending in the 6th International Health Sciences Conference. It was interesting to hear all of your presentations, and you can join for the rest of the conference in the other halls or watch it online. So thank you all for coming here and have a nice day.
Hello, everybody. Welcome to the 6th International Health Science Conference, Obstetrics and Gynecology, Neonatology and Pediatrics session. My name is Atėnė Simanauskaitė and I will be leading the session today. First of all, on the behalf of Student Society, Scientific Society of Lithuanian University of Health and Sciences, I would like to thank our patrons, Frazenius Kabi, Roche, Medita, Origmeda, and others for helping us to organize this conference. We believe that it provides an opportunity to all participants to share their achievements and interest in various biomedical fields. We hope that this conference will help build friendly relationships and professional, of course, and share experience in fundamental medicine, biomedicine, odontology, pharmacy, and public health with young scientists all over the world. Of course, I would like to express our gratitude for all of the reviewers and jury today. So I would like to announce that today we have Associate Professor Laura Malakauskienė, also Associate Professor Lina Jankauskaitė, and Professor Rasata Melienė. We kindly ask jury members to remain all the session after the points were counted and the winners will be announced. So before starting the session, I would like to remind you some rules. That today we will hear 8 presentations and all of the presentations will be evaluated by the jury, and based on the average of score given by the jury, we will choose one winner of the session. And the winner will get great sponsor awards such as gifts from Bioderma, Sapiens, Chrysostomus Bookstore, Origmeda, Gintarinė Vaistinė, Filman, and Medita. And the winners will receive their gifts after the session. And moreover, presentation should last no more than 7 minutes, and after that we will have 3 minutes of discussion for juries and listeners' questions. And also please note that if your presentation lasts longer than 7 minutes, we will ask you to go to the final slide and finish your presentation. And I ask jury to stay to fit in time as well for discussion. And moreover, each presenter will receive a certificate that will be sent to their emails after the conference. Maybe you have more questions before we start our session? No? Then best of luck to all presenters. And now I would like to start with the first presenter, Vaida Žitinevičiūtė, to give us her presentation named Pregnant Women Knowledge and Attitude Towards Fetal Ultrasound.
So, hello dear colleagues, my name is Vaida Žitinevičiūtė, and today I will present you the topic of pregnant women knowledge and attitude towards fetal ultrasound. So, as we all probably know, ultrasound is one of the main tools providing objective information about fetal health during pregnancy, and it has additional psychological value to the mother developing maternal bond. And even though it's been almost 6 decades since first fetal ultrasonography, there are actually a lot of misinformation and myths spread among pregnant women till this day. So that is why we wanted to evaluate pregnant women knowledge and attitude towards safety of obstetric ultrasonography. So we created an online survey that consisted of demographic questions, obstetrical history, and 8 true or false statements that you can see on a screen. And don't worry that they are in Lithuanian, because we will cover all of them just in a few seconds. So we had 167 participants in the survey, and vast majority belonged to the age group of 25-34 years old, and almost half of them were first-time pregnant. Now, 77% of women declared that ultrasound is completely safe during pregnancy, and 1/5 of respondents say that it is partially safe, while actually no woman said that it is unsafe during pregnancy. And there was no significant correlation between age and attitude towards ultrasound safety during pregnancy, although we discovered that multifarious women tend to rely on ultrasound safety more often than first-time pregnant women. Now we will discuss all 8 true or false statements. So various studies show that 3D, 4D ultrasound is as safe as 2D ultrasonography, but actually 1/3 of women do not agree with this first statement. And the second statement suggests that prolonged and frequent ultrasound examination can affect the fetus in a similar way to radiation. And it is of course, it is a false statement, but actually 1/3 of our respondents actually do believe that ultrasound can affect in a similar way to radiation. Now, to be fair, 3D, 4D ultrasound is a very good tool to evaluate, for example, anatomy, the face anatomy of the fetus. But when it comes to taking measurements or evaluating blood flow, circulation, 2D ultrasonography is way more reliable tool. So this statement is actually false, and even more than half of our respondents actually do believe otherwise. Now, fourth statement suggests that ultrasound examination of the fetus can accurately determine the duration of the pregnancy, but the accuracy actually depends on various aspects such as experience of the ultrasonographer, the position of the fetus, so it is not 100% accurate. Although both of these statements are false, women still believe otherwise. So now we can see that these charts are way greener, so that is good news. And we can see that actually the accuracy of ultrasound determining the sex is 99%, but it is not 100%. And talking about the measurement of the fetal weight, well, it depends on the position of the baby, as I said, and various aspects. So once again, both of these statements are false, but we are quite happy that the vast majority of our respondents answered it correctly. And the seventh statement is considered to be false, since various recommendations suggest that there is no need to perform the ultrasound examination until 11th week of gestational age, although more than half of our respondents would go to gynecologist just right after a positive pregnancy test. And the eighth statement is obviously false, but 10% of our respondents still believe that sound waves emitted by ultrasound can adversely affect fetal hearing. So, responding to true or false statements regarding fetal ultrasound, women show that their knowledge is actually above average, and the median of correctly answered questions was 5 out of 8. And no statistically significant correlation between correctly answered questions and number of previous pregnancies was observed, although women under 25 answered statistically significant more questions than in an age group of 25, 34 years old. So to conclude, age of the mother does not have impact on attitude towards ultrasound safety, and vast majority consider it safe, although multifarious women tend to rely on ultrasound safety more often. And younger women have more information regarding safety of obstetric ultrasonography, and the best known fact is that ultrasound does no harm to fetal hearing, while the least known fact is that 3D, 4D ultrasonography is not always more accurate than 2D ultrasonography. So that would be all information from me, and if you have any questions, I hope I can answer them.
Thank you for your presentation, and now I will ask the jury to ask the questions.
Okay, thank you for your presentation, and I would like to ask, what is your personal input here? What work you made by yourself?
Actually, we did the survey by ourselves with me and Lena Damaitene, and all the statistical not measurements, like all the statistical data was collected by me, and I used SPSS to get the results and do the presentation, so it's quite a lot.
Can I ask? It's really nice presentation because there's really nice graphs and your English is perfect.
Thank you.
So it's congrats for this. I have a few questions. So first, maybe I forgot already how many older women, for example, than 30s or 25, because you said that it does not depend, or?
Yeah, we have it right here. So,
okay.
Yeah, so all
okay.
Above 35, they were like...
Yeah, my question just was because it's an online questionnaire, so some age group is more active maybe, you know, online.
But we spread the survey on a Facebook group, which is called depending on the due date of the woman.
Okay. So it's only one group?
Two, actually.
Okay, two groups.
Yeah, it's 2 months of those groups.
Okay.
Yeah.
So did you collect the data where those women come from, like village, rural area, cities? Because it could be influenced, you know. Did they know what is 3D and 4D and 2D? Did they know the difference?
Well, we didn't ask. Yeah.
So you know, there is it could be some bias.
Yeah.
You know, on online questionnaires, it's always as this.
Yes.
So I'm not very keen of online questionnaires because there are a lot of bias on that, but definitely you have a nice size of population.
Well, there were a lot of discussions in that group. Because
did you exclude some surveys? Were there any
no,
exclusion?
because all of them were answered like fully, so we used
all were answered fully, okay. And did you include some covariance? Because for the bias, you need to, you know, adjust the data for some covariance?
I don't understand the question, sorry.
It's fine. Okay, so that's all for me.
Too much for the start. Thank you, Vaida. You have presented your work very nicely. I think it's a high criteria for presentation, even at the beginning. So for that, for my interest, I would ask just your how to say, mentor, and you have designed that questionnaire by yourself.
Yes.
What were the criteria for the correct and not correct answers? Do you had something from the literature or from your doctor's experience? Because some questions that, for example, you decided that women asked truly or not so truly, they are a little bit discussed. So again, how strong was your questionnaire and that evaluation with criteria?
Yeah,
how you think?
We try to every information to cover with references, and of course my mentor helped a lot with this, and we agreed that there are a lot of questions that are very discussable, but we still have to evaluate somehow if it's more correct or more incorrect. So we try to have the feeling which one is actually
where opinion of the woman's flows and then goes, yeah? So for the start, it's good. Thank you.
Thank you.
So thank you for your presentation once again. And now I would like to ask Paulina Samsonaitė to present her presentation, Breastfeeding of Newborns Born in the Baby-Friendly Hospital in the First Year of Life.
Hello everyone, I am Paulina Samsonaitė, and today I'm going to present to you our scientific research, breastfeeding of newborns born in the baby-friendly hospital in the first year of life. The WHO recommends that children initiate breastfeeding within the first hour of birth and be exclusively breastfed for the first 6 months of life. Lithuania has created favorable conditions for breastfeeding according to the WHO recommendations, because at the present time, there are 17 maternity hospitals in the country that have the name of a baby-friendly hospital. According to the data of the Lithuanian Institute of Hygiene, in 2015, 32% of infants under 6 months of age were exclusively breastfed, and in 2019, almost 40%. However, a small number of studies have been conducted in Lithuania on the peculiarities of breastfeeding. And after identifying the breastfeeding problems faced by Lithuanian mothers, it is possible to improve breastfeeding courses for pregnant and lactating women, recognize the risk factors, and pay more attention to breastfeeding the newborn in the hospital. That's why our research aim was to analyze the peculiarities of breastfeeding cessation in infants born in a baby-friendly hospital. And it was a mixed retrospective and prospective study. We performed it in the Hospital of Lithuanian University of Health Sciences Kauno Klinikos in the perinatal center level 3 with the name of Baby-Friendly Hospital. Our aim was to examine 642 healthy and full-term infants, 37 weeks of gestation and more, who were born to healthy women in 2019 and exclusively breastfed from birth. And 642 mothers who gave birth were interviewed about breastfeeding characteristics by telephone. And now I want to present our results. Of all newborns, up to 6 months of age were breastfed almost 77%, and until 12 months of age, almost 60%. And the most common causes for breastfeeding cessation were personal reasons, 26%, and infant rejecting breast, 25%. And in this chart, you can see all breastfeeding termination reasons depending on the duration of breastfeeding. As you can see, the main cause for breastfeeding cessation for up to 3 months of age and 3 to 5 months of age was insufficient lactation hungry infant, was 46 and 49% respectively in both groups. And analyzing breastfeeding termination during 6 to 11 months of age, it was found the most common causes for cessation was infant rejecting breast, 33%, and personal reasons, 22%. And more than 1/3 of all infants who were older than 1 year did not want it to be breastfed. As well, we wanted to see if sources of information about breastfeeding influenced the breastfeeding duration. So mothers who breastfed for only up to 3 months of age were more likely to use social networks as a source of information about breastfeeding than mothers who breastfed for a longer period of time. And mothers who were breastfeeding for 3 to 5 months of age used literature, 14%, as a source of information more often than those who breastfed until 12 months of age. And the most common source of information about breastfeeding among women who breastfed from 6 to 11 months of age and 12 months of age and more was personal experience. And now I want to conclude our results. 3/4 of all newborns born in a baby-friendly hospital were breastfed for up to 6 months of age, and more than half 12 months of age and more. The most common reason for breastfeeding cessation until 6 months of age was insufficient lactation, a hungry infant, and 12 months and more, personal reasons. All mothers, regardless of how long they breastfed, most relied on personal experience as a source of information about breastfeeding. So that will be it. Thank you.
For your nice presentation. Now, of course, I would like to ask our jury to ask questions.
Thank you very much for your interesting presentation. I am neonatologist, so it's related to me. So I would like to ask you about the weaknesses of your work. How do you critically think about it?
I think we made some mistakes analyzing the results. I think it will be like, because we have a really big amount of data, it was like almost 650 women and children, so we had to analyze the children charts and to call mothers too and to put everything together. And I think we put some people from some babies from the different period of age, months, into the one group. So we didn't like see all the results correctly. And yes, I'm thinking.
So I would like to add, because work was done in only one hospital. And
yes.
And our hospital is tertiary level hospital, not a second A or second B hospital. So the results can be different.
Yes, because
we have a huge amount of babies, and our approach may be a little different. So.
yes, thank you.
Okay, very nice. Really, thank you for the data. I have a few questions. First, about ethical consent.
Yes.
Did you have it? Was it regional ethical consent, or was it, what kind of consent did you get?
We had the University Bioethical Center consent. We just didn't put in the abstract, but we had it.
Yeah, because you performed telephone interviews.
Yes.
So yeah, with the student, I'm not sure if student ethical consent covers it. So, but whatever. So why you chose this year, 2019? Was it special year, or I don't know what is? I don't know.
Yes.
You know it better. Just.
Me and my colleague, we just we were asked to help residents. And they had like data, so we just had to like get to know to everything. And
so the study was ongoing then?
Yes, yes.
Okay.
We joined the study.
Okay, so what is your personal opinion about that? Most of the women go to social media and get knowledge and data from there. So what do you think? Your personal opinion? Is it okay, or and what from this opinion, what you get, what your recommendations would be, for example, because it's very important, yeah?
Yes, as we can see, it's like we had a list. We saw that women who use social media just breastfed until 3 months, like more. Yeah, but I think that the help from other women to each other would be like. Could improve breastfeeding, because you can, I don't know, but mothers know that it's hard to do practical breastfeed than to know theory. So it's like better to share experience, yes.
Thank you for your presentation and for those truly answers, because even not for young scientists, for older ones, it's very important to know mistakes and weaknesses and represent them, because it's the science, it should be like that. So thank you for the source for this site. And now you are a little bit like expert of breastfeeding and about baby-friendly hospitals. I think not all the auditorium know that. Maybe you know, or maybe somehow you would answer. Maybe our neonatologist will cover that question. But what would be the best criteria for breastfeeding? Because you have got the answers that 76.8 women breastfeed till 6 months. It's okay for baby-friendly hospital? Because this percent, I think, not for all of us, it doesn't mean nothing.
Yes, okay.
It's good or not, because baby-friendly hospital has some criteria and something that we are working for, and on what idea. So maybe you could explain for us. Thank you.
I don't really remember, but I think in 2019, in the whole world, only 30% of babies were breastfed until 6 months of age. I don't know if I'm correct, but so the World Health Organization has a criteria to, I don't remember how to say, but achieve bigger numbers by 2050. I don't remember the number. So if the neonatologists can help with the.
So our percent is quite good, I think.
Yes, I think yes, but it's like World Health Organization wants to achieve more by the initiative of a baby-friendly hospital.
Maybe Rasa could comment.
I could comment that baby-friendly hospital covers only the time babies in the hospital, and leaving hospital 85% of babies have to be breastfed, of healthy mature babies, but there is no word about prematurity or about the age of 1 year. It is initiative in the hospital, it is baby-friendly hospital. If you have a good start, you will have a good also results.
Outcome in the later, yes.
But in general, we are okay with this. Okay, so thank you. So
just one
again, you have to start to be better for Lithuanian women.
Yeah.
Okay, thank you.
We have to conduct more, bigger research of all Lithuanian hospitals. Thank you.
Thank you, Paulina, once again for your nice presentation and nice answers. And now I would like to ask Eglė Gelšvartaitė to present her presentation, Symptom Analysis of Pediatric Patients with Abdominal Pain that Predict Hospitalization.
Good afternoon, everyone. My name is Eglė Gelšvartaitė. I'm a 6th-year medical student, and I would like to present the study that me and my colleague did, symptom analysis of pediatric patients with abdominal pain that predict hospitalization. I would like to start with the introduction. So acute abdominal pain is one of the most common complaints at the pediatric emergency department. And it is highly important to distinguish between cases which need urgent surgical treatment, such as appendicitis, and those which can be treated at home. And timely hospitalization can be crucial for the effective treatment of acute conditions. So that's why we aimed to analyze what symptoms could predict the hospitalization of children with abdominal pain. The methods we used, we did a retrospective epidemiological study of PED patients with abdominal pain. We collected data from 1st to the 30th of September of 2018, and the analyzed month was selected randomly. Data were collected using electronic medical record system, and we included the data that we gathered was referral time, age, symptoms, clinical examination data, final diagnosis at PED, and outcomes, whether patients were hospitalized or discharged. And also we compared the data between 2 age groups, and all of the patients were divided into older and younger than 10 years old. So our results. In total, we analyzed a retrospective data of 254 children. 47.2% of them were male. Most children were older than 5 years old, and girls presenting with abdominal pain were older compared to boys. 63% of pediatric patients with abdominal pain presented within 24 hours from the onset of pain. 35% of children were hospitalized. 49 of them were diagnosed with appendicitis. 5 had other surgical abdominal conditions, and 25 had gastroenteritis. In these charts, on the left one, you can see all of the clinical examination data that we gathered and we analyzed. So it was abdominal muscle rigidity, nausea and vomiting, abdominal pain, migration, loss of appetite, fever, and peritoneal irritation. And on the chart on the right, you can see the frequency in the hospitalized group and the discharge group, and which symptoms were more common to which group. So we saw that for the hospitalized group, abdominal pain, migration, and peritoneal irritation were significant symptoms. However, there was no significant difference in hospitalization based on age groups or such symptoms as fever, nausea, vomiting, or decreased appetite. And as said in the previous slide, the patients with reported abdominal pain migration were hospitalized more frequently and with peritoneal irritation. However, in the multivariate analysis, only children with peritoneal irritation were 9 times more likely to be hospitalized compared with others, and none of the other factors such as lab tests or results of abdominal ultrasound were associated with hospitalization. And our conclusions, assessing the data of patients presenting with abdominal pain to the PED, it is apparent that symptom of peritoneal irritation was more likely to be associated with hospitalization. It is not surprising, as peritoneal irritation is a highly sensitive diagnostic factor for appendicitis, and no other symptoms were significant in predicting hospitalization. So these are our references. Thank you for your attention, and I can answer any questions if you have them.
So we are looking for your questions here.
So thank you for your nice presentation. I would like to ask, did you analyze data in smaller age group? Because I'm a neonatologist, it's very interesting for me if we have baby abdominal pain until the 1 year old are hospitalized or not.
Mm-hmm.
What did this analysis?
No, in this study we only focused on the 2 groups, younger and older than 10 years old, because we wanted to especially concentrate on appendicitis, and we read in the literature that it's more common in children than 10 years old, and we wanted to see this correlation, if we could see that.
Thank you. And next my question is about the consultation of surgeons. What percentage of these babies were consulted by surgeons?
Thank you, that is a good question, but I don't think we gathered this data as well, but it's a very good point. If we do any studies like this in the future, we would like to include this. Yes, thank you for this. Yes.
Thank you for the presentation, and similar question, but from obstetrics and gynecology field. You told that abdominal pain for the girls, it came more high with the numbers with the age. Again, any differences, any ideas? Maybe it was with some gynecology complaints or something, especially for the teenagers.
Mm-hmm.
Any data like that?
Yes, thank you for your question, but as well, I'm not able to answer this because we focused more on the appendicitis symptoms, and the whole study was
It's
towards
okay, just
that.
for us it's very
Yes.
interesting because it comes
but
closer
these are very
to
good
our
points
field.
for future
Yeah.
studies, so thank you very much, yes.
But again, for such a general idea, there are no good specific symptoms just to know which child should be hospitalized, who not. How it looks for you at this site?
Yes, so for me, from our study, but I believe that physicians should take extra care and always notice children who present with peritoneal irritation, because that might be a sign that they need hospitalization. So that is a sign that we should be.
The strongest? The strongest one?
Mm-hmm, yes.
Okay, thank you. You have no words here. No, I want the experience from the representative. Thank you.
Thank you very much.
Thank you, Egle, for your delightful presentation. And now I would like to ask Emilia Borauskaitė to present her presentation, Impact of Gestational Diabetes Mellitus on Breastfeeding Practice.
So, hello everyone. My name is Emilia Borauskaitė, and together with my colleague Gabriela Norikytė and our supervisor, Professor Dalia Stonienė, we conducted a study called The Impact of Gestational Diabetes Mellitus on Breastfeeding Practices. We believe that this topic is of great importance because gestational diabetes mellitus rate is increasing throughout the years. For instance, from 2015 to 2019, it increased more than 4 times and reached around 12% in Lithuania. According to the literature, women with gestational diabetes mellitus are less likely to start breastfeeding than healthy women, and mothers who start breastfeeding a newborn do it for a shorter period of time and are around 3 times less likely to feed a newborn exclusively with breast milk. So our aim was to evaluate the influence of gestational diabetes mellitus on breastfeeding practice during the first month after delivery. We conducted the study in the Lithuanian University of Health Science Hospital, Kaunas Clinics, from October 1st to November 31st of year 2021. And we analyzed medical data of 82 healthy full-born newborns who were born by healthy nulliparous women. We divided newborns into 2 groups, mothers with mothers who have gestational diabetes mellitus and mothers who didn't have it. And of 32 women with gestational diabetes mellitus, 20 had A1 type and 12 had A2 type gestational diabetes mellitus. We analyzed newborns' documentation to find out about mode of birth, newborns' APGAR scores, birth weight, skin-to-skin contact, breastfeeding in the first 2 hours, and overall breastfeeding and supplementation rate in the hospital. Mother's telephone survey 1 month after delivery were performed to assess breastfeeding and related problems. And later, we did the statistical analysis. So, in the results, we can see that around 2/3 of women gave birth vaginally, and newborns' APGAR scores median at 1 minute was 9, at 5 minutes it was 10. Birth weight was around, mean of birth weight was around 3.5 kilograms, and the majority of newborns had skin-to-skin contact in the delivery room and were breastfed during the first 2 hours. Around 40% of newborns were in the gestational diabetes mellitus group, and around 60% of newborns were in the non-gestational diabetes group. And we noticed no significant difference between newborn groups while analyzing these characteristics. However, we noticed that a group of gestational diabetes mellitus newborns was significantly more frequently supplemented with formula on the 2nd day of life. During the first month of life, the majority of neonates were fed breast milk, and there was no significant difference in how mothers feed a newborn during the first month of life between these 2 groups. What we found the most interesting is that the most common reason for supplementation at the hospital and 1 month after birth was insufficient milk production. Although there was no significant difference in supplementation reasons in the hospital, however, we found that the gestational diabetes mellitus group were significantly more likely to be fed with supplementation due to lactation deficiency. So to conclude, a group of gestational diabetes mellitus newborns was significantly more frequently supplemented with formula on the 2nd day after birth, and after 1 month, neonates in the gestational diabetes mellitus group were significantly more likely to be fed with supplementation due to lactation issues. So thank you for listening, and I will try to answer all your questions. Thank you.
So thank you. It was really nice. Huge work was done. And I would like to ask you, you stated that in 5 years, 4 times increased diabetes. How you can explain? I think you read some literature in
Yeah, well, this
days.
data was taken from the Institute of Hygiene, and in 2015 it was like around 2.5% of mothers had gestational diabetes, and in 2019, which is like the latest data that we have, it's around 12.5%, so it's more than 4 times. And I think the reason is, well, according to the literature, is our change of life, our eating habits, our physical activities habits, and so on. And also, there are a lot of reasons that they are speculating, but like there are no proofs. So maybe we're just diagnosing these kind of conditions more because earlier in years there were no such attention to these conditions.
Or maybe we use different criteria for diagnosing, I think. Yes, lower values of glucose, so it's, yeah. And it was very good data, I think, because almost 87% of babies had skin-to-skin contact, so it's nice. But we can reach 90, I think, in this. And how do you think, what are the reasons the babies are supplemented more in this group? It's very important to work, to speak with these women.
Yes. Well, our research was done also in the baby-friendly hospital. So I believe that the health staff is like very friendly and also like educating these women. But according to the literature, nulliparous women, older women, women who use insulin as the therapy for diabetes are less likely to start lactation early. And I think that our results show this, and that's the main reason why. And we need to make more, to give more attention to these kind of women, because we need to help them start the lactation early, and therefore they will breastfeed their babies over the months in the future.
Thank you.
Okay, really nice data, actually. Did you check the worldwide data? What do they suggest? What the pathogenetic, for example, mechanism of this? Because there should be, yeah? If there is insulin, for example?
Yeah, we tried to check it, but there are no like proven data. There are a lot of like
speculation.
Guessing. Yeah, speculation.
Okay, I just have one suggestion for you, just to check on those mothers and those babies, like according to glucose levels, you know? What was before the new values of glucose was implemented, and after, because maybe there are going to be some differences, or there are going to be some other answers to your research.
Yeah, it's a great idea. Yeah. Thank you.
Thank you. I will be, my answer will be true. I got the message from wiser prorector, so I missed a few of your ideas, so can't ask because Linda will tell that it was written. So so coming to the start, that really even fasting leukemias in the first trimester of the pregnancy, those criteria have been changed. So that's why, as you mentioned, we have paying more attention to that, but our evaluation, our diagnostic have changed, so we have a wider amount of such a woman with this situation. But just not, again, suggestion, not a question for you. You could make a good mix from your presentation and from few other works that have been done already, because even it would be interesting to know what is the opinion and knowledge of the women, how they understand what is wrong with that gestational diabetes, like it was with ultrasound of the colleagues, because there can be some even biases or misunderstanding. They do not understand well, and maybe that does not encourage themselves to breastfeed, to do that in the right way, or just to seek for the help. So I think, again, it's a good work for the start and to go on with this idea. Thank you.
Thank you. Thank you for the questions.
Thank you, Emilia, for your presentation. And now I would like to ask our guests, Abdullah Monzer, to present his presentation named The Opportunities of Lung Ultrasound in Children with COVID-19.
Hello, everyone. First of all, it's a pleasure being here with you today. My name is Abdullah Monzer. I'm a sixth-year medical student of VN Karazin Kharkiv National University in Ukraine. Today, I'm going to be presenting the opportunities of lung ultrasound in children with COVID-19. So during the COVID-19 pandemic, lung ultrasounds has gained an incentive for development. The preference of lung ultrasounds should be given to the following cases. Number one, for young children, especially because CT scans are a quite difficult task for them. Also, when it's necessary to diagnose a large number of patients, and when transport of ill children is impossible. Furthermore, pocket ultrasounds are easier to disinfect, which is a really important factor, especially now with the COVID pandemic. Also, the absence of radiation makes it possible to re-examine and evaluate dynamic changes of patients. However, a downside is that the ultrasound signs of lung involvement are not highly specific. The aim of our research was to establish the futures of ultrasound pictures of lung lesions in children with COVID-19. During the period of October till December 2021, 565 children received a lung ultrasound at the St. Zenaida Sumi Children's Clinical Hospital, of which 492 children in total were diagnosed with interstitial syndrome of varying severity. The etiology of pneumonia was established on the basis of PCR data, which were by detection of RNA using a nasopharyngeal swab, and an ELISA method using antigen IgM antibodies in blood. Ultrasounds were also carried out using the Fujifilm Arietta 50 ultrasound scanners and linear sensors 10 to 12 volts. The Commission of Bioethics of our university, VN Karazin Kharkiv National University, found that the study meets the ethical principles of medical research conducted on humans. On the next page, we see here the results. 75% of the COVID-19 patients we saw had bilateral lesions in the lungs, in both lungs and the lobes. The following typical features were the multiple bilateral B lines, also called or referred to as caput medosa, that were fixed and confluent. We can see them over here in the following bottom pictures. We can see the parallel lines, and these here are the B lines seen in both photos. With the progression of the disease, the number of the B lines merge up to the appearance of a single echopositive image, and that's referred to as a white lung appearance as a reflection of the interstitial syndrome. We can also see that here clearly in both photos below, that we can see a huge area of the white lung appearance. The next most frequently diagnosed symptoms, which was shown in 71% of our cases we saw, was the change in the pleural line. So the changes that happened is the increase in the thickness and its unevenness. And we can see that in the bottom left picture. And on the right side, where we see the thickness has increased significantly, and it's also in shape and unevenness. And then the less common symptom, which was around 39%, and that we can see here below. And this includes the consolidations, the subpleural consolidations. With the COVID-19, these consolidations were always determined against the background of interstitial syndrome. Furthermore, the studies during the influenza A, H1N1, and H7N9 cases allowed to establish the ultrasound features of viral pneumonia. The following were shown. So we had, first of all, the signs of interstitial syndrome, the B lines, which we saw previously. We also saw the small subpleural consolidated multifocal bilateral changes. Thus, the COVID-associated pneumonia is determined by the same ultrasound signs as with any other viral pneumonia. To conclude, the ultrasound signs of COVID-19, which we mentioned earlier, are the multiple bilateral B lines. With the progression of disease, the appearance of the white lung appearance as a reflection of the interstitial syndrome, as well as the increase of thickness or unevenness of the pleural line and the subpleural consolidations. It was determined that these ultrasound signs are not specific and are determined in viral pneumonia of any other etiology. Therefore, the diagnosis of COVID pneumonia in children should be based on a set of data from clinical, laboratory, and instrumental methods. Lung ultrasounds, therefore, do not replace and cannot be opposed to lung CT, but it's a promising additional method for diagnosing pathological changes in the lungs. I want to thank you for listening, and I hope that everyone is praying for peace in Ukraine and peace worldwide. Thank you.
Thank you for your presentation. We are with our hearts with you, and I would like to ask the jury if they have any questions.
Hello, and first of all, thank you that you are joining our conference, and it's really nice to hear such good data and good experience from your side, and best wishes goes back to you and to your hearts. And talking about your work you have done, just a very general methodological question, was your work retrospective or perspective? How it was done? Maybe I missed some details.
Okay, so according to our work, it was done like simultaneously with COVID patients currently in the hospital, and it was done like as a record of their progress with the COVID or respiratory disease. So I would say, but in general, the research was like the goal of the research was to look at the future use of COVID pneumonia and diagnosis using the ultrasound, lung ultrasound.
And you personally, you were evaluating the images, photos already done, or during some process? What was your work?
That was during, as we said, during the October till December in 2019. That's where the data was from. So during that time, we started gathering the data with the help of our mentors and doctors, and we gathered that in the hospital in St. Zenaida.
So sorry, the data, that means that photos and images?
Yes.
Evaluating them with those signs that you discussed. And it was 565 children, so that was the amount of the general data you have evaluated?
Yes.
Okay.
Hi, really nice work, and definitely all the peace with Ukraine. So I have a few questions. First, did you have any reference for the ultrasound, for example, for COVID lung? Did you get reference as other diseases, or did you compare with X-ray? Was it more sensitive, more specific? How you performed those tests?
Mm-hmm. Yes, of course, we did use a comparison method. We looked at the difference between also CT scans specification as well as X-rays, and we used that together, and we concluded that there are many similarities with the etiologies and signs that we saw on the ultrasounds, and therefore we concluded like together that it's a general thing. The ultrasounds can be used as an additional method and not as a primary method of diagnosis.
Okay, so your choice, primary choice is CT scan, or?
Yes, so like ultrasound, as we concluded, should not be a primary method, but only an additional method, especially during the COVID pandemic, because it's easier to use and it's safer for children.
Okay, so how often did you perform those ultrasounds? Because ultrasounds could be repeated, yeah, like 2 days, every 2 days, every 4 days, whatever. So how often did you perform, and how often did you compare the signs?
Exactly. Yes, so that's the advantage of using the ultrasounds. So how often it happened, it depends on the case, individual case of the patient, but it occurred more than minimum 2 times per week, plus minus, according to each case. And that way, like, we were able to gather information on the progress of the situation.
Hello, it is nice to have you here today. And I would like to ask you, who did these investigations? It is pediatrician or is it radiologist? Because the result, it depends on the experience.
Yes, so with the help of our mentor, Dr. Olga, she was in touch with the doctors there. So they were in a team of pediatrics and also a radiologist working together. But because of the current war, we weren't able to gather all the necessary documents showing like all the necessary required documents to show you here today as well.
And one more question, did the ultrasound pictures correlate with the severity of the disease?
One more time, please, sorry.
Did the ultrasound pictures you have correlated with the severity of the disease? More severe disease, more bad ultrasound picture?
Yes.
So thank you.
I understand. Yes. So regarding to the correlation, of course, most of the signs appeared quite similar to the CT scans. Regarding severity, we did see in the lung ultrasounds the increase in thickness, as we said, and the white lung appearance did appear when the progression of the disease was, proved in that significant cases. So they did correlate, yes.
Thank you for your presentation once again. And now I would like to invite Gabija Raižytė to present her presentation named The Negative Impact of the COVID-19 Lockdown on Children with ASD, a Systematic Literature Review.
Hello everyone, thank you for the opportunity to attend in this conference. My name is Gabija Raižytė, and together with my colleague Greta Butkutė, we made a systematic literature review called The Negative Impact of the COVID-19 Lockdown on Children with Autism Spectrum Disorder. So as we all know, in 2020, countries imposed strict lockdowns due to COVID-19, causing disruptions in families' routines and negatively affecting children with autism spectrum disorder mental health. Children with ASD comprise a particularly vulnerable population during COVID-19, not only due to disrupting routines, but also due to limited access to therapy, which result in changes of symptoms. The aim of the systematic literature review is to present current knowledge of the negative impact of the COVID-19 lockdown on children with autism spectrum disorder. Various methods were used to conduct this thesis. A PubMed and ResearchGate databases search was done according to PRISMA guidelines. To narrow down the result, we used some keywords like autism, COVID, impact, or effect. And to reach the best result, filters like child from birth to 18 years and language English were applied. The screening process included reading titles and abstracts. The most relevant articles were selected, and their backward and forward citations were also inspected. Selected studies were fully read, resulting in an overall number of 14 articles included in this systematic literature review. After literature analysis, the results were summarized in the following 4 aspects. So first of all, behavior changes and worsening of the symptoms, like increased motor and vocal stereotypies, mannerisms, moodiness, irritability, and aggression were noticed. At least a third of the children with ASD showed an increased intensity or frequency in problem behaviors. and children who had already had problem behaviors prior to the pandemic were twice as likely to display more frequent or intense problem behaviors. Secondly, children who did not follow their routines were more anxious. Moreover, sleep quality and sleep-related problems worsened. There was difficulty falling asleep, bedtime anxiety, and daytime sleepiness increased, yet there were different finding results showing either increase or no change in night awakenings, hypnic jerks, rhythmic movement disorder, and sleepwalking. And finally, due to lockdown, decreased functioning of children with autism spectrum disorder was linked to reduced levels of pleasant emotions. In conclusion, this systematic literature review indicates several negative effects of the COVID-19 lockdown on children with autism spectrum disorder. Firstly, there was an overall increase in problem behavior. Secondly, children with ASD who did not maintain routines had higher mean levels of anxiety. Moreover, sleep disturbances increased. And finally, decreased functioning was associated with lower levels of positive emotions. Thank you for your attention.
Thank you for your nice presentation. And now I would like to ask the jury if you have any questions.
So thank you for your nice presentation, and I would like to ask you, notice that a lot negative effects children have in COVID pandemic, and what your recommendations could be for the parents, for the caregivers looking at that, how to improve situation? Thank you.
I think that telehealth is getting better every year, so maybe online speech therapists would be nice, but that's not the matter of parents, that's matter of the government. I think that. And parents should communicate with their children more. Try to make routines, try to do everything the same at the same time, because children with ASD, they love routines.
Mm-hmm.
And that's what they, yes.
Thank you.
Yeah, very nice. I have a few questions for you. First, what are criteria for systematic review?
Sorry?
What are the criteria for systematic review?
The criteria?
Yes, exactly.
To review all of the literature that is in the internet.
Mm-hmm. So your review is a literature review, it's not a systematic review.
Okay. That was the first time, so...
Yeah, so you were 2 students doing this,
yeah.
Yes? Okay, I recommend you to have a mentor in the future.
Yeah.
Okay, because if you checked on Prisma,
mm-hmm.
There should be some criteria mentioned already. Then why you chose ResearchGate as a database? Just answer why you did it. I mean, I don't know. So just the question.
Because it's there.
Mm-hmm. Because ResearchGate is more, it's not a database like database. It's more for the communication, for whatever. I mean, yeah. But definitely you can get open access of the articles. It's easier. What types of the articles you had in your research?
There was case series.
Okay.
Also...
Did you include reviews or meta-analysis?
Yes, meta-analysis, I think no. I can't remember now.
Did you include reviews?
Reviews, no.
No, good. Okay, what else? I had some, but I think there are too many questions. And another thing, which countries did you include? Because, when you do a review, it's better to analyze by the country because it can be different, as you told, in the healthcare system,
yeah,
etc.
I think that the countries were more from high incomes. Okay. I remember Italy, I remember US, probably.
Okay, so you could present it as well. That's your result because you can summarize in a nice
That's
table.
a good point, thank you.
Yeah, okay, thanks.
Thank you for your presentation. And again, methodological question, technical maybe. How long does it took from you, with your colleague, to go through these abstracts and to make this research presentation when you started?
Maybe 3 weeks, I think, 2 weeks of not very intense work.
About month in general for everything.
Yeah, but not very hard work of month.
Okay, so it was very fast, I think.
I'm sorry, just one question. Don't be afraid. No, because you show only 14 articles, okay? So what was your primary search? How many you had in return when you ran PubMed, for example?
I can't answer that because I don't remember.
You don't remember, okay.
But probably about 50.
About 50, okay.
I don't know.
Can be, yeah. Oh, and you did not include the search, like, for example, that it won't be 10, it's 2 years, yeah? Only you included 2 years?
Yeah,
definitely. Yeah. Okay, because the beginning. Thanks.
That's it? Okay.
Thank you, Gabija, for your presentation. And now I would like to ask Eligija Telešytė to present her presentation, Analysis of Management Approaches of Ectopic Tubal Pregnancy and Their Effectiveness.
Hello everyone, my name is Eligija Telešytė and today I'm going to present analysis of management approaches of ectopic tubal pregnancy and their effectiveness. My scientific advisor is Professor Eglė Bartusevičienė. Ectopic pregnancy occurs in approximately 2% of all pregnancies and can be life-threatening. The most common location is the fallopian tube, which accounts for 96%. There are 3 management approaches: methotrexate therapy, surgery, and expectant management. Historically, ectopic pregnancy was managed surgically, and until 2016 in Kaunas Clinic's obstetrics and gynecology clinic, conservative management approaches like methotrexate therapy and expectant management was administered up to 10% of all cases per year. But in current practice, the preferred therapy is with methotrexate. So our aim was to analyze treatment methods of tubal pregnancy and their effectiveness in 2021 at the Department of Obstetrics and Gynecology, Lithuanian University of Health Sciences. We conducted a prospective analysis of tubal pregnancy management approaches and all women who were treated during the period from 1st of January to 31st of December in 2021 and agreed to participate in the study were included. We collected data from medical records and completed patient questionnaires, which included management method and its effectiveness, HCG dynamics until unreachable level, and women's awareness and satisfaction of treatment. So here are the results. 72 women were included in the study. 34 undergone surgery, and that was 47.2% of all women. 25 women completed the follow-up questionnaire, and from those women, 1 needed reoperation. So that makes 96% the effectiveness of surgical approach. 31 women were eligible for methotrexate therapy. That makes 43.1%, and 21 women completed the follow-up questionnaire, and 4 women from those required surgery. So the effectiveness of methotrexate therapy is 80.9%. And 7 women had expectant management. It's almost 10% of all women, and 4 of them completed the follow-up questionnaire, and 1 needed additional methotrexate therapy, which makes 75% effectiveness. And the adverse effects occurred in 6 women treated with methotrexate, and most common was nausea. A total of 34 women followed HCG dynamics until the level was unreachable, and the average time in weeks did not differ between groups. And it was 3.6 in surgery group, 4.5 in methotrexate therapy group, and 3.7 in expectant management group. And there was no statistical significance between groups regarding women's awareness. 86% of all women agreed that information on tubal pregnancy and its management approaches were understandable. 96% understood the choice of treatment method used, and 64% were satisfied with the management approach. And so, in conclusion, more than half women with tubal pregnancy received conservative management approach. The most effective management approach was surgical. The average time in weeks did not differ between treatment methods, and the majority of women were well informed, and 2/3 were satisfied with the treatment. So thank you for your attention.
Thank you for your presentation. And now we are waiting for your questions.
Okay, thank you. Thank you for a nice and clear presentation. Maybe I'm losing a little bit my attention, but it's my field. Please explain once more. As I understood, all the women have answered those questionnaires, 100%. But that means that you made the, the target group were just those who have completed the questionnaire? Because I think there were more women with this pathology, or not?
Yeah, so we asked women who were hospitalized, in 2021 to participate in the survey and complete the first questionnaire. So 72 women completed the first questionnaire. And then we explained that we will send the second questionnaire 2 or 3 months after the hospitalization to find out their HCG dynamic, because they can do to see the concentration somewhere else, not in the CONUS clinics. So 50 women answered the second questionnaire.
Okay, thank you.
Yeah, thank you. Very nice presentation. I just have one technical question about the effectiveness of what's your opinion? Is the sample size enough to measure the effectiveness and to show it?
No, but these are just like results from year 1, because there are not a lot of women who have ectopic pregnancy. It was, I believe, 84 in total in 2021, but we're continuing our research this year, so we believe we will have a bigger sample.
Okay, thank you.
Thank you for the nice work, and I would like also ask who made the questionnaire? It was did by yourself or you took from somewhere?
No, this was originally made by me and my scientific advisor.
Okay, and what are the weaknesses of your work also?
Maybe some women do not understand how to fill out the questionnaire, especially the second one, because we asked to write all the dates and the concentration means, and sometimes it's just they write, well, it dropped out in 6 weeks, so we don't have the data. How did it go until unreachable level?
Thank you.
Thank you.
Thank you, Aligia, once again for your presentation. And now I would like to invite Angelika Šlegerytė to present her thesis, Vaccination Status and Parents' Attitude to Vaccination of Pediatric Patients with Rheumatic Diseases.
So good afternoon, everyone. I'm a fifth-year medicine student, Angelika Šlegerytė, and I would like to present our topic about vaccination status and parents' attitude to vaccination of pediatric. Oh. Gerai. Man tiesiog padėjo. Atsiprašau. So I would like to present our topic about vaccination status and parents' attitude to vaccination of pediatric patients with rheumatic diseases. To start with, pediatric patients with autoimmune diseases are more prone to different infections preventable by routine vaccination, However, with increasing anti-vaccination movements and different immunosuppressive treatments prescribed, vaccination coverage remains low in this children population. The aim of our work was to assess the vaccination status of children with rheumatic diseases and the attitude of parents towards vaccination of children with chronic rheumatic diseases. We created an anonymous questionnaire and this questionnaire was lasted between January 2020 and January 2022, and data analysis was performed by using SPSS software. The questionnaire was distributed to 36 parents, and the response rate was 58.3%. 21 people answered the questions. The most common disease among the children whose parents responded to the questionnaire was juvenile idiopathic arthritis, and the mean age of patients was about 12 years. 40 patients were under any kind of immunosuppressive treatment for 3 months or more. And as you can see in the diagrams, the majority of parents claim to know about the high risk for infections due to the disease and immunosuppressive treatment, and 81% of patients were vaccinated according to the national immunization schedule. Even so, 47.6% of the respondents indicated that the child with rheumatic disease had received additional vaccines. And as it's shown in the diagram, the most common vaccine was against tick-borne encephalitis. Almost 80% of respondents stated not having heard about additional vaccination. More than a half of parents stated they did not consider the disease to be a contraindication for vaccination. And however, we found no correlation between the group of parents or between the group of those who assume they get sufficient information about vaccines and the rate of additional vaccination. 90 respondents indicated that the most information about vaccines is provided by the general practitioner. 76.2% of respondents would accept the physician's suggestion to vaccinate their child, and more than a half of respondents who answered the question would like to discuss the vaccination questions with a general practitioner or a pediatric rheumatologist. To conclude, the majority of patients in this survey were fully vaccinated according to the national immunization schedule. A number of patients have also been vaccinated with additional vaccines. Most parents presume the child's disease is not a contraindication for vaccines and would agree to vaccinate the child by the recommendations of a physician. And the survey results showed the need for additional information for parents regarding vaccinations for children with rheumatic diseases. And there are the references.
Thank you for your interesting presentation. Oh, we are waiting for questions.
Okay, I can start. Okay. Thank you very much for your nice presentation. I have a few questions. So first is about bioethical consent. Did you get it? It's
Yes.
like already like technical question.
Yes, we got a bioethical.
University
Yes.
bioethical consent. Okay, and then the response rate was not super high. Yeah.
Yes.
So what are the causes? Did you know? Did you like I don't know?
We gave these questionnaires by our doctor, Aušra Šnipaitienė, and she gave for the patients, and some parents, they didn't answer a lot of questions, just 21, I guess, was fully answered the questions.
So others just, you excluded, okay, so there was not like response rate, but I mean, because response rate, it means that you get, for example, only 21 questionnaire back, but I mean you get more, just not fully answered, yeah?
Yes, yes.
Okay. And another question is, did you check, for example, the correlation between treatment or severity of the disease? How they answered, for example, maybe those with severe disease, you know, the parents were more, I don't know, less keen of vaccination or more keen, and the same with the treatment, because, you know, hormonal treatment, for example, they are more maybe afraid.
We check a few correlations, but there's no between the correlation, because I think we have not enough patients who answer the question, and that's why we didn't get the correlation right.
Okay, thank you.
Thank you for your nice work, and I would like to ask one more question. Because your work was done in the last years, maybe you had in mind to ask about COVID vaccines?
We started this work before COVID time, because that's why it's lasted 2 years, because it was the COVID time, and when we create this anonymous questionnaire, it wasn't the COVID that time.
Thank you for the presentation. For me, it's interesting, what was your personal input in data, in spreading questionnaires? You told that not, so what was, what did
We created the questionnaire anonymous, and our mentors, Aušra Šnipaitienė and Milda Šeškutė, they help us to create the normal, but a lot of questions was created by me and Gintarė Butonytė. And we use the SPSS by us, and
you have worked with the results, yes, with everything, yes. Yeah? But about the spreading, giving the material, that questionnaire for the parents, you were not involved together with your colleague,
no,
just the doctors?
The anonymous questionnaires was spreading by the doctor.
Mm-hmm. So again, it's not for you, but for all the students, how to say, the home take message that how much you will be involved even in this situation, the data will come back to you, because usually we are leaving some there with questionnaires and that doesn't work. So maybe it was not just like mistake or something, but maybe in such a case, if you were sitting or coming, giving to the hands those questions and even maybe some recommendations, please answer till the end. It would be, yes, not calling, but because you have done, it's a good idea, it's a target group and everything looks very nicely, but you just have just 36 parents, so it's not representative. Thank you.
Okay.
Thank you, Angelika, for your presentation. And now I would like to invite my colleague Gintarė Galdikaitė to present our thesis, Comparison of Applied Treatment Method for Gestational Diabetes Mellitus and Obstetric Complications.
Hello everyone, my name is Gintarė Galdikaitė and I'm a fifth-year medical student at the Lithuanian University of Health Sciences. And I would like to present today my colleague Atėnės Simanauskaitės and mine research entitled Comparison of the Applied Treatment Method for Gestational Diabetes Mellitus and Obstetric Complications. We would like to express our sincere gratitude to our scientific research supervisor, Associate Professor Gitana Ramonienė, for all of her help and guidance. To begin, I would like to give a short introduction. So gestational diabetes mellitus is classified by treatment into two categories according to White. A1 is when glycemia is corrected by lifestyle changes, meaning a diabetic diet and physical activity. A2 is when glycemia is corrected by lifestyle changes and insulin therapy. It is worth mentioning that insulin therapy is given only if, despite adequate lifestyle changes, there are 3 or more pathological glycemias per week. The objective of our study was to determine obstetric complications related to gestational diabetes mellitus treatment method. We performed a retrospective study at the Čerčyry Teaching Care Center, the Hospital of Lithuanian University of Health Sciences, the Department of Obstetrics and Gynecology in 2020. As you can see on the right, we included 880 women in our study and separated them into two groups according to treatment. So group 1 was treated according to White A1, and that consisted of 70.5% of women, and group 2 was treated according to White A2, and that consisted of 29.5% of women. Medical data was collected from the hospital's database and archive, was processed with Microsoft Office Excel, and analyzed using IBM statistics for frequencies T and chi-square tests. Results with the value of p less than 0.05 were considered statistically significant. Now to begin with the results, Table 1 shows the socio-demographic characteristics of our patients. And here it is notable that patients in Group 1 were statistically significantly younger, while patients in Group 2 were significantly older. To conclude Table 2, the comparison of obstetric history, we can see that in Group 1 there were more primigrava and nullipara women, while in Group 2 there were more multigrava and multipara women. If we were to look at unfavorable obstetric history, we can see that in this department, Group 2 is leading. Moving forward to Table 3, the distribution of patients' pre-gestational BMI, it is notable that Group 1 patients more often presented with low or normal BMI, while Group 2 patients more often had a BMI greater than 30, and they lead it in obesity as well. The continuation of Table 3 shows the distribution of patients' weight gain, and here it is visible that the average weight gain during pregnancy was higher in Group 2 patients. Moving forward to Table 4, the comparison of gestational diabetes mellitus method of diagnosis, glycemia, and treatment of the disease, we can see that by fasting glycemia in the first prenatal visit, more often Group 2 patients were diagnosed, while with oral glucose tolerance test later in the pregnancy, more Group 1 patients were diagnosed. It is interesting to mention that fasting glycemia was higher in Group 1 patients, while all of the oral glucose tolerance test parameters were higher in Group 2 patients. Moving forward to Table 5, the comparison of pregnancy complications, here it is notable that polyhydramnions were more often observed in Group 1 patients. Table 6 shows the comparison of labor induction method and outcomes, and it is visible that labor was induced more often to Group 2 patients. And if we were to look at method of induction, amniotomy, as well as induction with misoprostol, were more often performed for Group 2 patients, as well as cesarean section due to failed induction of labor. And lastly, Table 7 shows the comparison of labor complications, and here it is important to mention another measure, which is newborn weight, and we can see that in Group 2 it was higher, and so was the number for large for gestational age newborns, although fetal macrosomia was more often observed in Group 1 patients. To conclude our presentation, I would like to affirm some of the key results. So gestational diabetes mellitus is commonly treated with lifestyle changes and a diabetic diet. Indications for concomitant insulin therapy are more frequent in obese women. As I mentioned, higher fasting glycemia at the beginning of pregnancy was found more often in Group 1, while all of the oral glucose tolerance test glycemias were higher in Group 2. And there were significant links between the treatment method of the disease and these obstetric complications: cesarean section due to failed induction of labor, polyhydramnions, and macrosomic newborns. Thank you for your attention.
Thank you for your presentation. Now I would like to ask Jerry to ask questions.
So thank you for your nice work. I would like to ask now, Lina, about your bioethics committee permission.
Yes, we also have...
I stole it.
We have the university's bioethics.
Okay, it's enough.
Okay, really nice data, really nice statistics. Did you do by yourself?
Yes, I performed it with my colleague, Atena.
Okay, really great. Congrats on that. Another question is, did you check on worldwide data? Did you compare, for example, how it represents, how your data goes into the pool of?
Yes, we did check. Unfortunately, because the guidelines have changed, there are not a lot of data that we can check online, and therefore there are many research that has to be performed moving forward.
Sorry, why guidelines change? I'm not. I did not understand. Come again, just.
I mean, the guidelines for
diabetes. You mean?
Yes.
Okay. Because I think there are more data in general, but you can compare as well how it is represented. Yeah. Thank you for your presentation and for all of you, such attention for gestational diabetes, and I think it's the most interesting questions for students' research. Could you please come back to some results, because I wasn't reviewing your job, I think, if it's possible? Okay, if it's not, because there was one table about induction of the labor.
Yes.
And oxytocin group was mentioned there. How you think, is it clear it's good in this group to mention and to take the part with oxytocin? Is it for induction of the labor? Between these four methods, amniotomy, misoprostol, mechanical devices, and oxytocin.
We analyzed using oxytocin for induction of labor, although, as you can see, there are no statistically significant results.
Yeah, but it's okay. You presented everything okay, but how to say, if you would take pregnant woman, which you want to finish her pregnancy and induce her labor. So first of all, we are coming from amniotomy, misoprostol, and some mechanical maybe devices. Oxytocin, it comes a little bit, how to say, later, maybe already in the process. I mean, of labor already, that it's not good enough, and you want to stronger it with the oxytocin. Maybe you have discussed with your mentor, but in my opinion, I would have this question before if I would see maybe you would somehow change it a little bit. So this part comes to me because I wouldn't use that oxytocin group in this group. So I think a little bit different, maybe how to say, results you've got. So just, I don't know, theoretical and think just to that base. But presentation was clear. Thank you.
Thank you. That was a very good idea, and we'll keep that in mind. Thank you.
Thank you for your presentation, and I also would like to thank all of the presenters today for their delightful presentations. Let's take a 7-minute break while the scores are counted, and right after the break, we will announce the winner of the session. Kasai? Ai, gerai. Kaip, aš nesuprantu, peliukas čia neveikia. Attention, please. I would like to thank the jury for their work today. And thus, after counting all of the jury's points, I am delighted to announce that the winner of this session is Eglė Gešvartaitė, Andrius Daugela, and Lina Jankauskaitė, and their study entitled Symptoms Analysis of Pediatric Patients with Abdominal Pain that Predict Hospitalization. Congratulations, and I want to invite you here.
Thank you.
So this session is finished, and I would like to thank all the participants for attending this conference, and hopefully it was interesting. And now I would like to invite you, of course, to join the rest of the conference and come to listen to our keynote speakers. Today is Associated Professor Ignas Kalpokas. Of course, Eglė and your supervisor, don't forget to take a photo there. And also, if someone else wants to take a photo, there is a big wall to take them. So thank you all for your interesting thesis and work in science, and have a good day and have a nice weekend.
So, welcome to everyone to the 6th International Health Sciences Conference Cardiology session. My name is Arnoldas and I will leading this session today. First of all, on the behalf of the Student Scientific Society of Lithuanian University of Health Sciences, I would like to thank our patrons, Rasenius Kebi, Roche, Medita, OrigMed, and others for helping us to organize this conference. We believe that it provides an opportunity to all participants to share their interests and achievements in various biomedical fields. We hope that International Health Science Conference will help build friendly and professional relationships and share experience in fundamental medicine, biomedicine, odontology, pharmacy, and public health with young scientists of over the world. Additionally, I would like to express gratitude for all the reviewers and today's jury. I want to present now a jury, and it is cardiologist Professor Diana Žalia-Duonytė, Associate Professor Giedrė Bakšytė, Doctor of Science Rūta Dirsienė, and PhD student Audronė Vaitiekėnė. We kindly ask jury members to remain at the session until the points are counted and the winner is announced. Before starting the session, I would like to remind you some rules. Today we will hear 8 presentations. All of the presentations will be evaluated by jury. Based on the average scores given by the jury, we will choose one winner from the section. The winner will get great sponsored awards, gifts from Bioderma, Sapiens, Chrysostomus Bookstore, OrigMed, Gintarinė Vaistinė, Filman, and Medita. Winners will receive their gifts after the session. Moreover, presentation should last no more than 7 minutes, and after that, 3 minutes will be dedicated for questions from the jury members and listeners. Please note that if your presentation will take more than 7 minutes, you will be asked to go on the final slide and finish your presentation. Moreover, each presenter will receive a certificate that will be sent to their emails after the conference. So, best of luck to all presenters, and now we're starting. So, I would like to invite the first presenter, Simona Dužinaitė, and her topic is changes in left ventricle function and structure in patients participating in heart failure program.
So, hello dear colleagues, I'm Simona, and today I'm going to talk about changes in left ventricle function and structure in patients participating in heart failure program. To begin, the amount of patients suffering from heart failure is growing significantly every year. Some guidelines are set in order to reduce possible consequences and improve patients' quality of life. One of the main management program is heart failure program, which includes 4 visits to the hospital. During these meetings, topics of self-care like nutrition, physical activity, or harmful habits are analyzed, and patients are taught about heart failure, and diagnostic tests are performed. One of the most important tests is heart ultrasound, and during this ultrasound, important aspects such as myocardial structure, function, and hemodynamics are assessed. Our study aim is to investigate changes between left ventricle structure and systolic function parameters before and after 4 visits of the heart failure program. Moving on to the methods, our research included 99 patients with heart failure who had completed all 4 visits, and where was heart ultrasound examination and systolic function was measured by ejection fraction, which was calculated by Simpson's method, and the structure was reflected by left ventricle and diastolic diameter. And changes in the results of these tests were monitored, and cardiac function benefits were assessed. We used SPSS, and data significance was evaluated by using PR sample t-test, and the result significance was then p-value was less than 0.05. Our study included 99 patients, and women were 14.1% and men were 85.9%. Mean age was 63 years. In this slide, you can see a diagram which represents ejection fraction results. And the first visit for women was 24.99, and for the men was 35.43, and the normal ranges for women is from 22 to 72%, and for men is from 54 to 74. And of the 4 results, in women you can see changes. It was 29.71, and for men was 35.07. So you can see there was no statistical significant difference for women, but for men we found statistical significant results. Moving on to another diagram, you can see left ventricle and diastolic diameter result changes, and the mean for women at the first visit was 54.77%, and the normal ranges are from 37.8 to 55 to 0.2 millimeters for women, and for men the normal ranges is from 42.0 to 58.4 millimeters. So in this slide you can see statistical significant difference for, changes for men, and for included first and the 4th visit, and for women we didn't found statistical significant difference from the 1st and the 4th visits. So moving on to the conclusions, the heart failure program have shown improvement in ejection fraction and left ventricle and diastolic diameter measured by heart ultrasound. Additionally, the improvement in both results is considered statistically significant for men, but not for women, and it may be considered that statistically insignificant results were found because the number of female participants was too small. So thank you for your attention. We're looking for your questions. We just got data, which was like 99 participants, and the majority was men of that.
And how do you think, as we saw, ejection fraction for the women did not change, was actually the same? May it be because of the gender or other reasons? What's your opinion?
Me and my colleague were thinking about that because it would be better to analyze more females and to see how the changes are correlate. But on this this research, we had only 4 women, so it's very hard to say what would be changes.
So for the next work?
Yeah.
Thank you for your presentation. I'd like to ask, did you calculate index values of left ventricle and diastolic diameter? Maybe with indexed values you could find more significant results.
Yeah, but in this study we didn't do that, but maybe for the next we will do it. Thank you for your...
Thank you very much. That was a very interesting idea to check these things. What do you think would be the main reason for the improvement? Why did it improve? What's your thoughts? Maybe some better self-care or what?
Yeah, based on the self-care behavior scales, we saw that men had better physical activity, better, less, they didn't smoke after the 4 visits during the heart failure program, so maybe that's why it's these changes are better and significant for men.
Okay, thank you. Very interesting. Maybe for the future, it would be very nice to compare with the people who didn't go on this program and to see. It's really helpful, probably. Okay, thank you.
Thank you.
Maybe one more question. Do you have time? A short question. And who was doing the ultrasound study? There was one person investigator, or several investigators for the echo study?
There were some doctors who had investigated the ultrasound, and we just got the results and just described it.
Thank you.
No, it was few doctors to do that.
Thank you.
So thank you.
Thank you, Simona, for a great presentation. And now I want to invite the next presentation, Nojus Jotka, and give to us the presentation called QFR versus Visual Estimation, Guided PCI in STEMI Patients, Evaluation of the Quality of Life at 6 months Follow-up.
Hello, everyone. It's a great pleasure to be the part of this conference. And now I want to present, my name is Noyes, and now I want to present one of our studies, QFR. It's actually quantitative flow ratio versus visual estimation guided PCI in STEMI patients. It was evaluation of the quality of life at 6-month follow-up. So first of all, we need to know that about 50% of the patients presenting with STEMI have multivessel coronary disease. What it is? It is at least 50% diameter stenosis of at least 2 major coronary arteries. So what we can do, but to know, is non-culprit stenosis significant? Nowadays, we have coronary physiology methods which can answer it. Physiology-guided PCI is recommended worldwide. It's very important to mention that. So first of all, what coronary physiology methods are in the industry nowadays? You can see 4 different sections. The first of the section is all about computed tomography-based coronary physiology methods, where non-invasive and can be performed without intervention to coronary arteries. The second and the most popular is fraction flow reserve. It is often used and usually taken as a gold standard coronary physiology method. However, it requires adenosine to cause hyperemia and pressure wire manipulation, but to evaluate the pressure inside the coronary before and after stenosis. The third of the sections is about also invasive coronary physiology methods, but we don't require adenosine. Actually, we don't require hyperemia. For this reason, we're more comfortable for the patients, but we also require manipulation of the pressure wire, which prolongs the procedure. The prolongation of the procedure is not only additional stress for the patients, but it is also a higher dose of radiation for both doctor and the patient too. And the last section is all about the latest coronary physiology methods. And there you can see our investigated QFR, or quantitative flow ratio. It is based on the angiograms and can be performed after angiography. It is fast and can be performed days, weeks, or months after the angiography procedure. However, it is novel and requires more investigations into the clinical practice. For this reason, our team made a study which investigated the outcomes differences of QFR-guided versus angiography-guided non-culprit lesion PCI in STEMI patients. We included 76 patients with STEMI and at least 1 non-culprit lesion with intermediate diameter stenosis and a reference diameter at least 2 millimeters, according to visual estimation. It was a single center study, and the patients were included between February and June of the last year. All the patients were divided into 2 groups. The QFR-guided PCI group included 35 patients, and it was first group. And the angiography-guided or visual estimation-guided PCI group involved 41 patients and was called second group. The primary endpoint was the impact of a non-culprit lesion revascularization strategy on quality of life, estimated by the Sattel angina score. The physical limitations were classified into minimal when Sattel angina score was between 75 and 100, into mild, moderate, and severe. About 40% of the patients in QFR-guided PCI group said that they felt minimal physical activity limitations. It was 3.4% more than in the angiography-guided PCI group. However, the differences were not statistically significant. The similar situation was in the group of the patients who said that they felt mild physical activity limitations. It's important to mention that about more than half of the patients said that they felt mild physical activity limitations, but the differences between the groups were not statistically significant. Essential and statistically significant differences were found between the groups of the patients who said that they felt moderate physical activity limitations. More than twice of the patients said that they felt moderate limitations in the group of angiography-guided PCI than in the first group. Major adverse cardiovascular events, which in 3 months follow-up after the which in 3 months after the hospital discharge, as a secondary endpoint, were established to be statistically significant among the groups. The results show that patients had major adverse cardiac events approximately 2 times more often in the angiography-guided PCI than in the group of QFR-guided PCI. So our team made the conclusions that QFR can be used in STEMI patients. QFR-guided PCIs improve patient outcomes, reduce the risk of major adverse cardiovascular events. QFR-guided PCIs versus angiography-guided PCIs improve patients' quality of life and let them do daily physical activity without moderate limitations. This is our references. Thank you for attention. Do you have any questions for me?
And I have a question. Did you compare those groups according to other characteristics like age, gender, ejection fraction, Philip class?
Yeah, I got the question.
Because maybe they were unequal, so you cannot compare.
So we didn't in this one study, but I don't think so that it will be a difference between the gender or age. So actually we didn't. Yeah, we didn't in this one study. But I don't think so that it will be different.
So how you will explain why the QFR group showed better results in quality of life?
When angiography, do you mean?
Yes, how would you explain why?
So QFR, it's a physiology evaluation method, and it let us find hemodynamically significant stenosis, and also made a treatment, for example, to implant a stent. So for this reason, I think that angiography sometimes can. Okay, one of my colleagues wants to answer this question. Okay, Greta.
I would like to say that in this study, it was evaluated patients according other parameters and they were equal. We didn't mention this in this presentation. They were equal. These groups were equal. Thank you.
Thank you for your presentation. Greta saved noise. My question is about the statistical analysis. What kind of statistical methods did you use in this?
We use cross tabs, just a Chi-quadrat, Chi-square, and actually that's all.
Okay, thank you for your answer.
Thank you for your presentation. I also would like to ask, what is your own, as a student, role in this scientific work?
So I called to patients and asked the settle angina score questionnaire. And later we just collect all this data and we made a statistical analysis. Okay, and we have another one. Yes, and another of our studies is about quantum flow ratio suitability for evaluation of the physiology significance of intermediate non-culprit artery stenosis for STEMI patients in the acute phase. As I mentioned in the previous presentation, physiology-guided PCIs are recommended worldwide. It greatly protects patients from major adverse cardiac events in the future. Fraction flow reserve, also known as FFR, is a gold standard physiology evaluation method. Despite that, it prolongs the time of procedure, requires pressure while manipulations, requires the use of adenosine to cause hyperemia. The combination of all these domains is inappropriate to be used for STEMI patients. So if we have a non-culprit lesion which requires physiology evaluation, it should be performed in additional procedure. However, we have another one, physiology evaluation method, quantitative flow ratio. It is novel, non-invasive fraction flow reserve. Excellent agreement with fraction flow reserve and only half of the fluoroscopy time. As you can see on the table, correlation with fraction flow reserve is 0.94, but diagnostic accuracy a little more than 94%. Sensitivity is 95%, and specificity is more than 98%. Our study aimed to research numerical and treatment decision-making differences between QFR measurements in the non-culprit lesion in STEMI patients performed at acute coronary syndrome procedure and during the second stage procedure before PCI. We included 81 vessels of 68 patients who had STEMI and second stage PCI other than culprit artery. We included patients between June and December of the last year. The same coronary artery QFR was evaluated twice. It means that first QFR was evaluated during acute coronary syndrome PCI, and the second QFR was evaluated during second staged procedure. It was before PCI, and it was at least 3 months after the first QFR. As you can see on the chart, left anterior descending coronary arteries as a non-culprit in STEMI patients were evaluated mostly. Right coronary arteries were assessed rarely. We got stunning results when we estimated the correlation between two values of QFR performed during acute coronary syndrome PCI and staged PCI. As you can see on the chart, all of the evaluation agreements were very high and no less than 0.9. If we are talking about agreement of clinical treatment decision-making between first and second QFR, we can see that left circumflex and left anterior descending coronary arteries had no one misunderstanding. There was only one disagreement in right coronary artery actually between the first and second QFR analysis. In this case, the first QFR was 0.85, so it is not significant, and the second was marginal, 0.8. It's on the cutoff line. So our team made the conclusions that QFR has an excellent agreement between the acute phase and that 3-month follow-up period. Wider QFR application in acute coronary syndrome is reliable for treatment decision-making. QFR can be used as a single physiology evaluation method for physiology-guided PCIs. QFR decreases the patient's risk and increases the quality of life. Thank you, and this is our references. Do you have questions? Do you mean who is evaluating QFR analysis? So actually, in this study, QFR evaluated by me and Greta Jubrita. So
did you try to make between you two if your measurements are corresponding?
very important thing when you try to do coiffure analysis, it is don't input too much yourself, because software is really good, and if you have good angiograms, everything can be done without your intervention, without your input to software. So we actually didn't, but I think that, or we did. We did. You checked me later. So, so actually we did, and everything was fine.
So that's not so much, Stephen. It was one investigator of your part. It was not like you. Thank you for the presentation.
I just would like to check if I understood correctly. So the first invasive angiography was done during the STEMI, yes?
Yes.
And then the first GFR was measured, and the second one was 3 months after. Then was the staged PCI
after the acute coronary
performed,
syndrome
yes?
PCI procedure, yeah.
Okay, so for all patients it was performed 3 months later, yes?
At least 3 months,
At least, not less. Okay, thank you.
I want to congratulate, because it is very interesting research that you do with your team. So that's also very important. Of course, it's not that easy, but it's really very interesting. And my question is about your personal contribution to the work. What else did you do?
Yeah, so actually, as I said before, I evaluated some of the QAFA, and we just prepared that analysis and between the first and second QAFA.
Thank you.
Okay, thank you.
Thank you, Noyus, for these wonderful works. And so I now would like to invite Olesia to present us work called Association of Myocardial Injury Biomarkers and Left Ventricular Functional Parameters in STEMI patients treated with PPCI.
So, hello everyone. My name is Olesia Ivanova, and today I will be talking about association of myocardial injury biomarkers and left ventricular function parameters in ST elevation myocardial infarction patients treated with primary percutaneous coronary intervention. So to begin, acute myocardial infarction is a condition characterized as extensive myocardial damage with an active inflammatory response, which leads to left ventricular remodeling and functional impairment. And cardiac magnetic resonance imaging is a gold standard method for assessing left ventricular function. And additionally, CMR enables us to incorporate myocardial strain, which is a more specific approach in detecting early or subclinical left ventricular changes, and it is a key prognosticator in ST elevation myocardial infarction patients. And combining this sensitive technique with biomarkers for myocardial necrosis and inflammation may allow us to detect high-risk ST elevation myocardial infarction patients and improve the prognosis of adverse cardiac events. So the aim of our study is to investigate the relationship between left ventricular functional parameters from CMR and laboratory biomarkers in patients presenting with acute STEMI treated with primary percutaneous coronary intervention. Moving on to the methods, our study included 30 patients with acute ST elevation myocardial infarction, and laboratory tests such as troponin I, leukocytes, neutrophils, high sensitivity C-reactive protein, and C-reactive protein were examined after primary percutaneous intervention, and baseline CMR was performed 2 to 5 days after the acute coronary syndrome to all 30 patients. And after 6 months, the follow-up imaging was performed to 26 patients. And our CMR analysis included the quantification of left ventricular ejection fraction, as well as the global longitudinal and global circumferential strain using feature tracking technique. And these parameters were carried out using MEDIS 3.2 software, and the differences between follow-up CMR and parameters were compared with correlations. And the differences between baseline and follow-up CMR parameters were compared, and CMR results with those laboratory findings that I mentioned before were found the correlations of them. And now I would like to talk about the results. So in this slide, you can see a table that represents differences between baseline and follow-up CMR parameters. So as you see at the follow-up, there was a significant improvement in all those parameters compared to baseline. So left ventricular ejection fraction changed from 44.17 to 47.52. Global longitudinal strain changed from minus 19.29 to minus 21.87. And global circumferential strain changed from minus 24.22 to minus 26.28. And all those changes were statistically significant because the calculated p-value was less than 0.05. Moving on, in this slide you can see another table which represents correlation between CMR results and laboratory findings that I mentioned before, but only statistically significant correlations there are shown. Thus, there is no data about leukocytes, neutrophils, and high sensitivity C-reactive protein. So as you see, there was a moderate correlation between troponin I and baseline global longitudinal, global circumferential strains, as well as baseline left ventricular ejection fraction. And there was moderate correlation between troponin I and follow-up parameters, so global longitudinal strain and left ventricular ejection fraction. And also we found a moderate correlation between CRP and follow-up global circumferential strain. So we came to 3 conclusions. So first one was that a significant improvement in left ventricular functional parameters 6 months after the acute coronary syndrome was observed. And second one was that troponin I was significantly associated with almost all measured left ventricular functional parameters. And the third one, that CRP was also significantly associated with follow-up global circumferential strain. So that will be it. There's our references, and thanks for listening.
Very nice study and very interesting. 2 questions, one easy and the another one not that easy. The first question, what's your personal contribution to the work?
Yeah, I was responsible to contacting with our supervisor, and all the other work we shared equally with my colleague Simona. We had to collect all the data about CMR results from the photos and put it into Excel table. Then we did calculations with SPSS and did this presentation.
Okay, and the other question is about the patients that were included in this study. How did you include these patients? Because all of them, they got improved after 6 months. Usually in normal life it's not like that. Yeah. And 1/3 about patients, they have left ventricle remodeling and ejection fraction usually decreases in 6 months, and your all patients got well, as we see from this. So do you have any comment on this?
Actually, we just had the patients all, I don't know, everyone was after acute STEMI, and we just collected the data we had. So
maybe it was the difference between the anterior and inferior infarction, or it was the same localization of infarction?
We didn't were looking for that.
But that's for the future. It's an interesting thing to look at. Okay.
Thank you very much. A very nice presentation. And who performed the feature tracking studies? Was it one observer or a few?
A few, I guess, because there wasn't one doctor who did the CMR results that gave us. So I guess that wasn't the one person who did that.
Okay, but you didn't. So there were a few people who performed one for one patient, another for another
Actually,
one.
I don't know, but I guess that yes.
Okay, thank you.
I want to ask about inclusion criteria. Acute STEMI, it's a very inaccurate definition. So did you include the patients within some time limit from the start of the symptoms?
No, I don't know that, actually.
Okay, and then one tricky question about troponin level. We know that it's a very dynamic measurement. It changes during the time. So was it taken at some, according to the protocol, at some specific moment related from the start of infarction, or at which point troponin I was taken?
Like I think I mentioned that 2 to 5 days after...
About troponin, not about CMR study.
Oh, yeah, sorry. So it was done after the STEMI. I don't know, actually it was 1 day or 2 days, but I guess after the myocardial infarction occurred.
Okay, thank you.
Thanks, Alessia, for a great presentation. And now I want to invite to present to us next presentation, and it will presenter Gabriele. And her work called The Association Between Acute Coronary Syndrome and Local Earth Magnetic Field Intensity Changes.
So, hello everyone. Hello dear colleagues, dear jury. I'm Gabriele Jakoškaitė, as mentioned before, and today I would like to present our work about the association between acute coronary syndrome and local earth magnetic field intensity changes. Although several risk factors and comorbidities are known to contribute to progression of ischemic heart disease, environmental factors such as geomagnetic field are also known to have a significant impact on cardiovascular regulation. So further research is needed to assess if geomagnetic field strengthening in high frequency ranges causes a negative effect on cardiovascular disease. So our work aim was to identify correlation between the changes in local earth magnetic field intensity and patients with STEMI and non-STEMI myocardial infarction. Now talking about the methods, it was a retrospective study of 1,667 patients who were admitted to the Hospital of Lithuanian University of Health Sciences, Kaunas Clinics, between the 1st of January and 31st of December in 2019, and they were admitted to the hospital due to acute coronary syndromes. Now, the local earth magnetic field was measured by a magnetometer, which is located in Baisogala in Lithuania. Then the data from the magnetometer was collected and daily and then weekly averaged. We assessed the correlations between average weekly geomagnetic field strength in 6 different frequency ranges. They are listed here in the increasing order. So it was as delta, as theta, as alpha, as beta, and as gamma. And then the P6, which is the frequency range, the general frequency range from the 0 to 65 hertz. And then the average number of STEMI and non-STEMI cases per week. The study period was divided into 4 seasons. It was winter, spring, summer, and autumn. For statistic analysis, we used Microsoft Excel and IBM SPSS statistics. The Kolmogorov-Smirnov test showed that the data was normally distributed, and for analysis, we used descriptive statistics and Pearson correlation coefficient. P-value was considered statistically significant. It was less than 0.05. Now talking about the results. There were a total of 1,667 patients in the study. There were 64.4% male and 35.6% female. The mean ages of men were 65.2 years, and for women it was 74 years. Now talking about the distribution of acute coronary syndromes, a bit more than a half was non-STEMI patients. It was 941 patients, and it was 56.5%, and the rest were STEMI cases. Analyzing the data of 2019, it was observed that the presence of a stronger magnetic field in the frequency range of 32 to 65 hertz, which is marked, oh, you don't see it, okay, which is marked by the sign, increased statistically significantly in the STEMI group during the winter season. While in non-STEMI group, no reliable correlations were found. As well, we saw that there were no significant geomagnetic field strength changes in any other frequency ranges during the winter season in both STEMI and non-STEMI groups. As well, we saw that no reliable correlations were found in geomagnetic field changes in the spring, summer, or fall seasons. And to conclude, based on described data, we see that increased local geomagnetic field strength in high frequency as gamma or 32 to 65 hertz range correlates with a higher number of STEMI cases. However, further research is needed to see how the local Earth magnetic field intensity changes correlates with acute coronary syndromes. Thank you for your attention. Do you have any questions?
Thank you very much for good statistical analysis, first of all. It was really nice. And so I understood that this correlation was found only in the winter season. Is that right?
Thank you for your question. Yes, that's correct. We saw the significant correlation only in the winter season and only in the STEMI group.
Mm-hmm. Maybe you can compare with the data from other studies and authors. Yeah. Do they find the similar results? Or?
Yeah, if we compared with other studies and the similar results were seen. However, it is needed
to do a bigger study because the local Earth magnetic field changes every year differently. So it is needed to do the bigger study with several years to see is there any statistically significant changes and correlations.
Okay, thank you very much. It was really an interesting idea. And what do you think, what would be your thoughts? How could you explain why only the winter season?
That's probably because the local Earth magnetic field, the change was strongest in this winter season, but I cannot say the right answer probably. It's still, yeah.
Thank you, Gabriele. My question is about your practical recommendations, about the knowledge that you have from your research. Yes. So what suggestions, so what to do with this that we know, that in the winter we have that correlation?
I think, thank you for your question. Well, I think that as well, bigger studies is needed, but now in this year we see that in winter there was maybe patients who have STEMI, they are more susceptible of this changes in local Earth magnetic field, and maybe if we can see how these changes are during the years, how they changes, maybe there could be some lifestyle recommendations for the patients with heart disease.
Or maybe for doctors to get ready for the patient.
Maybe, yeah.
And what's your personal contribution?
So with my colleague Giedre, we collected the data from medical history, and then we made the statistical analysis.
Thanks for questions.
Thank you.
Thanks, Gabriela, for your interesting thesis. And now will be my work. So it's an honor to introduce our research work at this conference and share to you some interesting facts. So first of all, I want to present my team. It's me, student Arnoldas Leleika, cardiologists, medical doctors Agneta Verbickienė, Justina Jurevičiūtė, Professor Olivija Gustienė, and Associate Professor Tomas Lapinskas. And our work is called Relation of Myocardial Strain and Structural Parameters in STEMI Patient After PPCI. First of all, the risk of sudden death and progressive heart failure remain important medical targets. And the objective is to propose the most accurate diagnostic criteria for predicting the patient's long-term prognosis. And cardiac strain is one of more precisely can give us to precise information about regional contraction abnormalities which can be detected prior to left ventricle ejection fraction. And the analysis of 10 randomized trials shows that the relation between functional and structural parameters are useful for predicting the risk of recurrent events within 24 hours after STEMI. And here you can see illustration of different cardiac magnetic resonance sequences. And here lead gadolinium enhancement, especially T1 mapping, shows very detailed information about myocardial damage. and while T2 sequence shows identify area of the edema, which is another structural parameter. And this is an example of edema-based area at risk by T1 and T2 mapping indicated by black arrows, and corresponding myocardial infarction size indicated by red arrow, you can see here. And we decided to fulfill this research with the main aims: to prove a relationship between functional parameters such as global, longitudinal, and structural, circumferential strains, and structural parameters, infarct size, area at risk, and microvascular obstruction. It was evaluated for patients with acute STEMI as a prior prognostic tool for left ventricle evaluation. And 51 patients were included in our study, and initial CMR was performed on 2 to 5 days interval after diagnosis of STEMI, while follow-up study was completed 6 months later. Analysis of CMR was performed using MEDIS suite, and strains of different chambers were analyzed using feature checking technique. And I want to say that structural parameters were evaluated not for all sample size, but only for 31 patients of this sample. And the differences between functional baseline and follow-up CMR parameters were compared, and the correlations between functional and structural measures were investigated. And in results, you can see that in the demographical analysis shows that the biggest group was from 50 to 69 years old, and most of them were male. There you can see functional parameters analysis from baseline to follow-up. And there was a significant improvement in left ventricle longitudinal strain, circumferential strain, right ventricle strain, and only one left atrial strain shows significant changes in atrial strains. And below presentation, you will see here functional and structural parameters relationship. So firstly, baseline functional parameters, ventricle longitudinal and circumferential strains were compared with baseline structural parameters, infarct size, area at risk, and microvascular obstruction. And this slide shows a moderately strong correlation between left ventricular longitudinal strain and infarct size at baseline, and follow-up as well. In this slide, you also can see that there was identified another moderately strong correlation between longitudinal strain and myocardium area at risk, which is another structural parameter. However, estimated functional parameter of left ventricle shows statistically significant but weak correlation with another structural parameter, microvascular obstruction. Another moderately correlation was between circumferential strain and infarct size, and we can see here a little parallel that longitudinal and circumferential strains both correlated with infarct size. Also here is moderately correlation detected with circumferential strain and area at risk, and atrial strains doesn't show significant relation with structural parameters except only, and it was left atrial strain, but this correlation was weak and reversed. And here you can see conclusion how functional and structural parameters correlated, and especially left ventricle longitudinal strain, circumferential strain with with baseline and follow-up infarct size correlated, and important to emphasize that this sample size should be expanded for precise results. But this information gives assumption that about strain accuracy in evaluation of left ventricle prognosis after myocardial infarction. And finally, we observed significant important changes and improvement in 6 months of longitudinal and circumferential strains, and they show significant relation with infarct size, area at risk, microvascular obstruction, and this combination of these parameters is becoming more valuable in cardioprotective studies focusing on myocardial ischemic reperfusion injury following PPCI as a prior prognostic tool for left ventricle evaluation. Thanks.
So thank you for your presentation. So my question is, so which one parameter do you suggest to use as the best one?
I am not expert, but this.
Coding your data.
How I said, I can't primarily to take one parameter, but this combination strains shows that correlation between structural parameters is very not very strong, but moderately strong. And structural parameters, I think it is very precise method to identify ischemic damage, myocardial damage. And this is not directly recommended, but it is shows that strains can detect improvement more accurate, can quantifying more accurate changes between period from diagnosis of STEMI and follow-up. I think it's my answer.
You know, all the investigators, they look for a parameter which could be very easy and you could do the measurements quickly, so that's the point probably of every research.
I want to say that my thing is left ventricle ejection fraction measures globally left ventricle, but it can be very tricky to evaluate myocardial infarction damage because it's globally not directly related with infarct size. My idea was that this size and relation with strains can be too prior to left ventricle ejection fraction.
You are on a very good way, but just don't forget that the most important thing is to find a parameter that correlates with patient prognosis. I mean, we need to find that worse prognosis patients and to try to escape them.
Thank you for this interesting work. I think it really contributes to the basic knowledge of what happens during myocardial infarction and what happens next. My question would be about microvascular obstruction. Because in many studies, it is a well-known parameter of poor prognosis, actually. And as far as I understood, you got a very weak correlation, with it. Did you do the qualitative measurement, like yes or no, or some quantitative measurement of microvascular obstruction, the size, in your study?
In our study, we don't specify very well about microvascular obstruction because the aim was detect only relationship between strain and structural parameters, but I think in the future we can do this work.
But you, anyway, you did the correlation, so it was just there is microvascular obstruction or there isn't, yeah?
Can you concrete more?
So I saw you did the correlation of strains with the microvascular obstruction.
Yes.
You prepared the results that it's weekly. So when you evaluated it, you evaluated if it is or it isn't, yes? Or you
Yes.
calculated the area of it?
No, not area, but
Not area? Okay.
only correlation.
Yeah, that's what I wanted to know. Thank you.
My question is maybe more theoretical. Did you check other authors' data? Do they also observe improvement, always improvement in myocardial functional parameters in 6 months or whatever
yes.
period? Or this is because of some inclusion criteria?
How I said in the beginning, that we, before this work, analyzed 10 trials, and when we find that suggesting was that correlation between functional and structural parameters of cardiac magnetic resonance are useful for determining the risk, but we don't specify very well. But our aims and was only detect relation and correlations.
But does it always improve? I mean, all your patients improve.
Yes, our sample in what we analyzed, they have improved strains.
Other authors also find the same. Do the other authors also describe that they always improve? This is because you included stable patients.
I cannot answer very well because I don't read very well about this, but I think that it is very tricky question. I need to more read about this. I cannot answer.
But maybe there were some patients who did not improve, only the average was like this, or all the patients improved?
All our sample, yes. And except we analyzed ventricular strains and atrial strains, and only in atrial strains it shows left atrial strain significant improvement, but right heart strains doesn't show a significant improvement, but left ventricular, longitudinal, and circumferential strain shows us that was significant changes at follow-up moment. Thanks. Thanks. So we go in the next presentation, and now I want to invite Žemina, and her topic is assessment of right heart pressures, geometry, and function in pulmonary hypertension patients, correlation between echocardiographic and right heart catheterization data.
So good afternoon, everyone. Thank you for coming. I would like to say that it's such a pleasure for me to be here today and to be able to present my work, my team work to you. And today I'm presenting you the topic, the study of assessment of right heart pressures, geometry, and function in pulmonary hypertension patients, the correlation between echocardiographic and right heart catheterization data. The aim of our study was to analyze the correlation between transthoracic 2D echocardiographic and right heart catheterization derived parameters of pulmonary artery pressures, right heart chamber size, and ventricular and right ventricular function. So a little bit of background for the start, and I would like to say that right heart catheterization is a gold standard test used to determine pulmonary hypertension after pulmonary hypertension is suspected by echocardiography. and research into how the invasively measured pressures of the right heart and pulmonary artery correlates with right-sided heart, geometrical and functional parameters is currently lacking. Based on literature, we have found about comparison of those two types of heart examination, more accurately comparison of systolic and mean pulmonary pressures. We decided to go more into detail, comparing not only pulmonary artery pressures, but also right heart chamber size and right ventricular function. And so our main objectives were to analyze the correlation between transthoracic 2D echocardiographic and right heart catheterization derived parameters of first pulmonary artery pressures, then right heart chamber size, and right ventricular function. This prospective study consisted of 41 patients with pulmonary hypertension, which was confirmed by right heart catheterization. It's monocentric study. We started this study on January 2021 and ended 2022 January. And following the recommendations of chamber quantification and echocardiography in adults, we measured parameters of right ventricular and diastolic diameter, right ventricular longitudinal systolic function parameters, like S' and TAPSE, right and left atrium diameters, and mean and maximal systolic pulmonary artery pressures. After echocardiography, patients underwent right heart catheterization, and from that examination, we got the parameters of mean and maximal pulmonary artery pressures, wedge and right atrium pressures. Then Pearson's correlation analysis was performed, and two-tailed probability value of less than 0.05 was considered statistically significant. To terminate our results, the average age was 57, with standard deviation of 14 years, with the majority of women. Of course, we divided our patients into 4 pulmonary hypertension groups according to World Health Organization. And we found significant correlation between maximal pulmonary artery pressure, of course, with mean pulmonary artery pressure. And there also was a significant correlation between right ventricular diastolic diameter and mean pulmonary artery pressure, and left atrial diameter with wedge pressure. Unfortunately, there was no significant correlation between right ventricular longitudinal function parameters, such as S', and TAPSE with mean pulmonary artery pressure, and there was no significant correlation between left ventricular ejection fraction and wedge pressure. And you can review results on screen. And to sum everything up, I would like to say that the mean pulmonary artery pressure estimated by right heart catheterization has a significant correlation with right ventricular diastolic diameter, but no with longitudinal function parameters. And although the right heart catheterization is the gold standard of pulmonary artery pressures estimation, echocardiography, as a more accessible examination, may provide clinically useful measures of pulmonary artery mean and maximal pressures in pulmonary hypertension patients. So that's it for today. Thank you for listening. And I would like to invite my colleague, Victoria, is that okay, to participate in discussion with me?
Okay, thank you for your presentation. And I would like to ask, were echocardiography and right heart catheterization performed at the same time, or what was time difference between these two tests?
We decided that we include patients that underwent echocardiography first, then right heart catheterization, and all of our patients, the biggest time gap between echocardiography and right heart catheterization was
68 days.
68 days. And perhaps it's due to COVID. And we didn't count that.
Okay, thank you.
Maybe some provocative question. So do you think it's still right heart catheterization needed?
Well, it isn't like we are saying that right heart catheterization is not needed anymore. Our study focuses on correlation between these two procedures, and we can just say it's gonna...
It's still a golden standard, and it's gonna be a golden standard because it's invasive procedure, and we thought that echocardiography, it could be an examination type more for patients follow-up.
Yeah, patients follow-up.
Great, thank you.
Thank you for your presentation, very nicely done. I'm not that inspired about echo here because the correlation is just moderate, so let's leave catheterization as well. I want to ask, what's your personal contribution in this work?
So our personal contribution was collecting the data, then analyzing it, putting it into Excel, then using SPSS, calculating all the correlations and all the information, and writing the presentation and everything, and that was our...
and also the idea to compare those two examinations.
Yeah, the idea was ours.
That's an interesting data. Okay, thank you very much. Good luck.
Thank you.
Thank you very much.
Thank you.
Thanks, Žemyna, for a presentation and the last presentation. I want to ask to come Egle, and her presentation will be about the impact of obesity on in-hospital clinical outcomes after recanalization of chronic total occlusions.
So, good afternoon, dear colleagues. My pleasure to be here today. My name is Egle Labanauskaitė, and I'm going to present the study that we did, which is called The Impact of Obesity on in-hospital clinical outcomes after recanalization of chronic total occlusions. Recanalization of chronic total occlusion is one of the most challenging and complex procedures in interventional cardiology. And CTOs can be identified in around 1 in every 5 patients who show clinical indications for coronary angiography. And talking about obesity, its worldwide levels have increased in recent decades. Obesity, as you know for sure, is linked to a higher risk in cardiovascular disease,
But despite the higher risk, the in-hospital outcomes after CTO PCIs remains unstudied in this population. So our aim was to investigate the impact that body mass index has on success rates, complications, and procedure characteristics among a large group of CTO patients who underwent percutaneous coronary intervention. So we had 420 patients who underwent percutaneous coronary intervention for at least one total occlusion. Patients were subdivided into groups according to their body mass index, and these groups were based on the World Health Organization definition. So we had 4 groups: normal weight, overweight, obesity, and very obese patients. In order to subdivide patients according to the complexity of the CTO PCI, we used the Japanese CTO score. And each patient had a composite safety endpoint evaluation which summarized complications: stroke, cardiac tamponade, vascular complications, or in-hospital death. So these are results, and the figure 1 shows the gender distribution. So the males made up the majority of the patients, 62%, and we had 38% of female. This is the figure 2, which shows the distribution by body mass index. So the majority of patients were overweight, 252 patients. We had 42 normal weight patients, 100 obese, and 26 very obese. This is the table 1, which shows the procedural characteristics. And as you can see, all body mass categories had a similar Japanese CTO score, and it was not statistically significant. The other characteristic was amount of contrast. Medium used and it was increased as the body mass index increased. Also, as you can see here, the procedure duration of normal body mass patients was lower as compared to the non-normal body mass index. And the fluoroscopy time also tended to increase proportionally with rising body mass index. And this is the figure 3, which shows in-hospital outcomes. And there was no statistically significant difference in procedural complications, which rarely occurred. The complications that did occur were mostly vascular, and they were mostly in the patients with not normal body mass index. And in 3 cases, cardiac tamponade occurred. And similarly, 3 patients were diagnosed with acute stroke. And no in-hospital deaths were recorded. So we came to the conclusions that this retrospective study indicates that body mass index has no statistically significant impact on in-hospital outcomes in patients with chronic total occlusion after percutaneous coronary intervention. This is our references. Thank you. And maybe you have some questions.
Thank you for your presentation. It was an interesting topic. What's your personal contribution in this work?
So the doctor collected the patients and I got the file. So I was analyzing the case histories, analyzing the data, putting it into Excel, and analyzing, after that, discussing it with a doctor, and they gave me some ideas, and I did the presentation.
Thank you very much for the presentation. I'm wondering why there was the idea that obesity should, well, what was your hypothesis? Why did you choose to this parameter?
Well, thank you. Well, we were actually discussing about the fact that obesity has obvious cardiovascular disease risk, but somehow we came to an idea that it should also has an impact on the complications and the outcomes after the CTOs PCI. So we did the research and there was not much information about it, so we decided to do it ourselves.
Yes, quite logical actually. But did you also check some other risk factors for the outcomes or only obesity? Well, I understand in this presentation that not, but maybe you checked and you didn't get any results too.
It was a couple that we didn't use in this presentation. It was triglycerides also, the concentration. That was I think it.
Okay, triglycerides. Thank you.
Thank you. It's an interesting hypothesis. And I just have a suggestion maybe for your conclusions, because I think you could add this conclusion that still the procedural characteristics are different for obese patients, and including procedural time and contrast medium. And I think still the outcomes for the patients are the same, but for the operator maybe it's not the same.
Yes.
Because of the specific characteristics of the procedure itself. So maybe knowing this could be also a practical recommendation to prepare for a longer procedure. And I don't know if it's possible. Still, the protection is very good, so I don't know if it's there for anything for improvement of radiation exposure and so on. But still, I think it's a very interesting study. Thank you.
Thank you so much.
Thank you. As our associate professor said, that contrast amount was higher in these obese patients.
Yes.
So maybe did you calculate differences of renal function after procedure?
Well, that's a great idea, but we didn't did it on this study. But I think if we're going to do a follow-up, that would be a great idea.
I think it will be interesting to check.
Yes.
The way it will change. Or...
Yes, definitely.
Okay, thank you.
Thank you so much.
So now I would like to thank all 4 other presenters for the delightful presentations and work. And let's take a 7-minute break while all the scores are counted, and right after the break we will announce the winners of the section. So I would like to thank the jury for their work today. And thus, after counting all the jury points, I'm delighted to announce that the winner of this session is Nojus Jotka and their work, quantitative flow ratio suitability for evaluation of the physiology significance of intermediate non-culprit arterial stenosis for STEMI patients in the acute phase. Congrats.
Thank you very much. I need to say stop, please. Okay, so thank you for that. And this is really important for our team. And but this award goes to our team. However, it is not so important as a thing, but the fact that more and more doctors know that we have non-invasive coronary physiology method, which is accurate and can be like a first coronary physiology method. So thank you for that, and I don't have a lot of words.
So the cardiology session has finished, and I would like to thank for all participants for attending the 6th International Health Science Conference. Hopefully it was interesting, and now I want to invite you to join the rest of the conference and come listen to the keynote speaker, Associate Professors Dr. Signas Kalpokas and another Associate Professor, Dr. Vincas Urbanas. Thank you for all your interest in science, and have a good day.